Am I audible and visible? Okay. A very good afternoon to all the panelists as well as all the participants on 4th day of COVID training. So today we are going to discuss about few topics which are important, especially in this COVID era. So we are expecting COVID third wave in most probably next month. So we should have a hands-on knowledge about how to manage these COVID patients. So an important component, especially in sick patients of COVID, is septic shock. So we are going to discuss about septic shock, followed by we are going to discuss, Dr. Nishant will be discussing about ARDS and its management. And after lunch, we are going to discuss about PICU management, hand hygiene, general care of the patient, and prevention of VAP, followed by MISC diagnosis and treatment, which will be discussed by Dr. Aisha Ahmed from AMU Aligarh. And after that, we will be discussing about handling of disease patient by Dr. Vineet Singh. So first topic is mine only. Myself, Dr. Neeraj Anand. I am going to present my lecture on septic shock and its management. So directly going to the topic, so I am going to discuss about how to manage septic shock in pediatric patients. So coming on to the learning goals. From today's class, we are going to learn how to recognize shock in a child, how we are going to classify different type of shock based on clinical features, and what are different type of shock, how the management differs between different type of shock, how do we plan for fluid therapy in different type of shock, and what are the vasopressors and inotropic therapy that are preferred in different type of shocks. So we are going to discuss all these topics. So coming on to the definition of shock. Shock is defined as a significant reduction in overall blood flow to the tissue, and hence there is failure to deliver adequate oxygen and nutrient to meet its need. So basically in shock, either the cardiac output is affected or the delivery is to the tissues is somewhat hampered due to different mechanism. It could be due to decreased fluid, due to decreased blood circulation, such as seen in case of hypovolemic shock. It could be due to cardiogenic cause, that is, there is decreased myocardial contractility, so ultimately leading to decreased cardiac output, or it could be due to abnormal vasomotor tone, leading to abnormal vasodilatation of different vessels, so ultimately leading to peripheral pooling of blood, or it could be due to mechanical obstruction to forward flow of blood, such as in case of cardiac tamponade or tension pneumothorax. So along with inadequate oxygen and nutrient delivery, there is also inefficient removal of byproduct of cellular metabolism. So coming on to the definitions, severe sepsis is defined as life-threatening organ dysfunction which is caused by dysregulated host response in response to infection. So along with toxins released from infectious agent, the host response is also responsible for different manifestations in severe sepsis. When severe sepsis is associated with cardiovascular dysfunction, then it is known as septic shock. Along with cardiovascular dysfunction, there could be associated other organ dysfunctions as well in case of septic shock. Septic shock is a subset of sepsis with circulatory and cellular metabolic dysfunction and associated with higher risk of mortality. Now coming on to the mechanism of septic shock. In case of shock, there is inadequate blood supply to different tissues, which ultimately leads to inadequate perfusion. This inadequate perfusion ultimately causes hypoxia. Due to hypoxia, there is shift from efficient aerobic metabolism to anaerobic metabolism, where lesser number of ATP is generated per molecule of glucose. So this ultimately causes energy deficit. And due to anaerobic metabolism, there is also lactic acid accumulation, which leads to metabolic.
Slides are not visible, Neeraj.
Okay, sir.
Slides are not visible.
Now it is visible?
Yes, now it is visible.
Okay. Sorry for the interruption. So we have already discussed about definition. We are now discussing about how to what is pathophysiology of shock. So due to inadequate perfusion, there is cell hypoxia. Cell hypoxia ultimately leads to shift from aerobic metabolism to anaerobic metabolism. So ultimately there is an energy deficit, as anaerobic metabolism produces only 2 ATP per molecule of glucose compared to 36 molecule of ATP produced during aerobic metabolism. And also there is production of lactate. Ultimately there is lactic acid accumulation, which leads to metabolic acidosis. So both energy deficit as well as metabolic acidosis leads to cell membrane dysfunction and failure of sodium pump. These cell membrane dysfunction leads to intracellular lysosomal release of digestive enzymes into the circulation. These digestive enzymes are toxic, which causes capillary endothelial damage, and ultimately this leads to dysfunction of different tissues and organs and cell death. Now coming on to the different stages of shock. In the initial presentation of shock, body's compensatory mechanism comes into place, and there is increase in heart rate to blood supply to different tissues depend upon cardiac output and vasomotor tone. So to increase, as there is decreased cardiac output, so to increase the cardiac output, there is increase in heart rate, because cardiac output is product of heart rate into stroke volume. So as there is, in compensatory mechanism, there is increase in heart rate. So the patient presents with tachycardia with minimal change in blood pressure. This is the compensated shock, and the blood perfusion to important organs such as CNS as well as heart is preserved during compensated phase. But as the shock progresses and the patient is not managed properly, the patient may land up into decompensated shock, in which there is signs and symptoms of decreased organ perfusion, and the patient will have additional hypotension associated with different manifestation of decreased organ perfusion. The patient, if not managed at this stage, also may ultimately land up into irreversible shock stage, and ultimately this leads to multi-organ dysfunction and death of the patient. Now, on the basis of mechanism, there could be 4 types of shock. It could be either due to decreased circulating blood volume, known as hypovolemic shock, or it could be due to decreased myocardial contractility, known as cardiogenic shock, or it could be due to abnormal vasomotor tone leading to venous pooling of blood into peripheries. So this leads to decreased preload and increase in decreased afterload. So this type of shock is seen in distributive shock. Examples of distributive shock include anaphylactic shock or septic shock, or in case of neurogenic shock. Or it could be due to mechanical obstruction of heart, which could be seen in case of cardiac tamponade or tension pneumothorax, or in duct dependent lesions. The clinical presentation depends on different type of shock. In case of hypovolemic as well as in case of distributive shock, the patient presents with quiet tachypnea. Whereas in case of cardiogenic shock, the patient will have tachypnea, which is associated with increased work of breathing. That is, the patient will have chest indrawing, subcostal, intercostal retractions, nasal flaring. So increased work of breathing will be seen in case of cardiogenic shock due to pulmonary edema. Increased work of breathing may also be seen in case of septic shock if the patient is having associated pneumonia and the patient is landing up with ARDS. So it could also be seen in case of septic shock. Tachycardia is common to all type of shock and is one of the earliest marker of shock. The patient of hypovolemic shock may have maybe hypotensive or normotensive depending on the stage of shock, whether it is compensated or decompensated stage, but the pulse pressure remains normal in case of hypovolemic shock. Whereas in case of distributive shock, the patient will have wide pulse pressure. On examination, there will be bonding peripheral pulses, and the patient may have patient may be normotensive or hypotensive depending on the stage of shock. In case of cardiogenic shock, the patient will have narrow pulse pressure with normal or low blood pressure. In all type of shock, there will be delayed capillary refill time, except for warm type of distributive shock, in which the capillary refill time will be decreased. That is known as flash capillary refill. Altered mental status, which is a sign of decreased cerebral perfusion, is seen in late stages of all type of shock. Distributive shock patients will have warm flushed extremities as there is peripheral vasodilatation. So, whereas in other type of shock, there will be cold peripheries, cold extremities. There will be favorable response to fluid in case of hypovolemic shock, as well as in case of distributive shock. But there will be advanced response to fluid challenge, especially if the patient present with fluid overload in case of cardiogenic shock. Now coming on to the mechanism how there is changes in preload, afterload, and cardiac contractility in different type of shock. The primary pathology in hypovolemic shock is decrease in preload, and to compensate for decreased preload and to maintain blood perfusion to important organs such as brain as well as heart, there will be increase in systemic vascular resistance. This systemic vascular resistance manifests as increase in afterload. So these patients will have decreased preload, increase in afterload, and as systemic vascular resistance has increased, so there is decreased skin perfusion. So it will ultimately lead to increase in capillary refill time in case of hypovolemic shock. Mixed venous saturation, which is an indicator of increased oxygen extraction at the tissue level, it will be low in case of hypovolemic shock. In case of cardiogenic shock, the primary pathology is decreased cardiac contractility. So as there is decreased cardiac contractility, there is also increase in end diastolic volume. So there will be increase in preload due to compensatory mechanism. There will be increase in systemic vascular resistance leading to increase in afterload. Capillary refill time will be increased. Mixed venous saturation will again be low. In case of distributive shock, the primary mechanism will be in abnormal vasomotor tone. So there is peripheral vasodilatation, which leads to decrease in systemic vascular resistance. Due to this decreased systemic vascular resistance, there will be decreased afterload. To compensate for this, due to venous pooling, there will be decrease in preload also in case of distributive shock. Cardiac contractility can be normal, or due to compensatory mechanism, the cardiac contractility may increase. Mixed venous saturation is high as there is peripheral venous pooling, so there is increased oxygen extraction at the tissue level. In case of obstructive shock, there is mechanical obstruction to contraction as well as relaxation of heart. So there will be decreased contractility in obstructive shock, and as there is decreased relaxation of ventricular chambers, so it ultimately leads to increase in preload, and there is compensatory increase in systemic vascular resistance leading to increase in afterload in these patients. Capillary refill time will again be increased, and mixed venous saturation will be low. Now, how to rapidly assess a patient of shock in case of emergency? So for this, we use pediatric assessment triangle. In pediatric assessment triangle, we look for appearance, work of breathing, as well as circulation of the patient. In appearance, we look for signs of decreased organ perfusion, such as reduced muscle tone, decrease in mental status. The child may present with weak cry, There will be decreased responsiveness, purposeless or vacant stare. There will be failure of child to recognize or respond to his or her parents. There is poor response to painful stimuli. In breathing, we have to look whether there is increased work of breathing or there is just tachypnea without increased work of breathing. That is known as effortless tachypnea. So effortless tachypnea is seen in case of hypovolemic shock and anaphylactic shock, whereas increased work of breathing is seen in case of cardiogenic shock, or if the in patient of septic shock if associated with pneumonia, or in case of tension pneumothorax. In anaphylactic shock, the patient will have additional features of anaphylaxis such as laryngeal spasm, stridor, and wheeze. In circulation, we will see for cold clammy extremities, there could be mottled appearance, acrocyanosis, and pallor in these patients, in patients of shock. Now, how to clinically recognize shock? As we have already discussed, capillary refill time will be increased in all type of shock except for warm shock. In case of warm shock, there will be flash capillary refill. That is, the capillary refill time will decrease from less than 1 second. So, blood pressure is not required to define shock. In shock, the blood pressure may be normal or low, and even increased BP may be seen in case of neurogenic shock. Mental status, the patient might will have altered level of consciousness in advanced stages of shock, and it is an ominous sign that is the patient is going to land up in multi-organ dysfunction. Urine output, which is a marker of internal organ perfusion. So urine output will be decreased in shock. Now coming on to the how to recognize the severity of shock. In initial compensated phase, the patient will present with restlessness, anxiety, and irritability, whereas in decompensated phase, the patient will be listless, apathy, confusion, and unconscious. In initial phases, there will be slightly increased heart rate, whereas in case of decompensated stage, there will be profound tachycardia with slow, irregular, and weak and thready pulse. In case of initial stages of shock, compensatory stages, the BP will be more or less normal, whereas in decompensated stage, the BP will decrease significantly. Pale and cold skin is seen in early stage of shock, whereas cold, clammy, and pale skin will be seen in decompensated stage. There will be slightly increased respiratory rate in case of early stage, and there will be rapid breathing, or there could be slow, shallow, irregular respiration in late stages of shock in decompensated stage. In initial stages, there will be slight decrease in body temperature, whereas in case of late stage, there will be significant toe to core temperature gap. In late stages, there will be decreased cerebral perfusion, ultimately leading to confusion and incoherent slurred speech. Decreased and absent reflexes will be present, and the patient will have dilated pupils, sluggish reacting. The patient may ultimately land up into multi-organ dysfunction and ultimately to irreversible shock and death. Now, typical 5th percentile BP cutoff, these already have been discussed in vital signs, but for to remember again, to rememorize, we could see if the patient in term neonates, if the BP is less than 60 millimeter of mercury for 1 month to 1 year of age, that is 12 months. If the BP is less than 70 millimeter of mercury, and for 10 years and older, if the BP is less than 90 millimeter of mercury, and for 1 to 10 years of age, BP less than 70 millimeter of mercury plus 2 into age. That is, if the child is of 5 years of age, if the BP is less than 80 millimeter of mercury, the patient is said to be in hypotension. So how to clinically recognize shock? For the purpose of management, the shock has to be classified into cold shock as well as warm shock. So in cold shock, there will be narrow or normal pulse pressure with weak and thready pulse with cold clammy skin, whereas in warm shock, there will be bounding pulses with wide pulse pressure with normal toe to core temperature gap. Coming on to the management, general management of the patient include increase oxygen delivery and decrease in oxygen demand. So to increase oxygen delivery, we have to start oxygen therapy to all patients of shock and titrate according to need. We have to give fluid according to type of shock that we will discuss later. We have to manage both hypo as well as hyperthermia. If the patient is presenting with hyperthermia, there will be increased oxygen demand. So we have to decrease the temperature of the patient. We have to correct any metabolic abnormalities such as hyperglycemia of the patient. We have to manage the blood glucose level, and the blood glucose level should be below 180 milligram per deciliter. 180 gram per deciliter. Depending on suspected cause, if the patient is having septic shock, we have to start antibiotics within 1 hour. If the patient is not responding to fluid therapy alone, we have to go for inotropic support. Mechanical ventilation is given if the patient is unconscious, GCS is below 8. So along with or the patient is not able to protect his airway. So in general management, we start with ABC. Airway, we have to protect. If the patient is not able to protect his airway, we might have to intubate the patient, especially if the GCS is below 8. Breathing, we have to start with 100% oxygen in all patients of shock and titrate according to SpO2 monitoring or according to PaO2. So we have to monitor the saturation and we have to titrate the oxygen depending on requirement. We have to establish IV access rapidly, and if not possible, if we are not able to gain IV access within 90 seconds, we should go for intraosseous access without wasting time. Capillary refill time monitoring and frequent blood pressure monitoring has to be done in all patients of shock. Laboratory investigations that has to be done in patients of shock. Arterial blood gas analysis has to be done to look for metabolic acidosis, PaO2, PCO2, as well as lactate level. Some ABG also give electrolytes also. We have to look for blood sugars. We have to maintain blood sugar below 180 gram per deciliter. We have to manage any electrolyte abnormalities, especially hypercalcemia or abnormal potassium levels. We have to do complete blood count to look for anemia or thrombocytopenia. According to child's need, we have to transfuse the patient. PTA, PTT, INR to look for any coagulation defect. Type and cross matching has to be done as we may require blood or platelet blood transfusion. Cultures, urine and blood cultures has to be sent, especially in case of septic shock. Intraosseous access, if we are not able to gain IV access within 90 seconds, we should directly go for intraosseous access without wasting time. Once we have gained IV access, we could remove intraosseous access later on. Equipment for intraosseous access, for part preparation, we will need alcohol swab or chlorhexidine, and along with that povidone iodine. We could use 18 gauge needle with trocar with at least 1.5 centimeter of needle length, 5 ml syringe, 20 ml syringe, and infusion fluid that is to be given. Analgesia, anesthesia, and sedation. If the patient is uncooperative and fighting, we may need anesthesia and sedation. Procedure, we have to identify the appropriate site. Appropriate site could be either proximal tibia, anteromedial surface 2 to 3 centimeter below the tibial tuberosity, or it could be distal tibia proximal to the medial malleolus, or it could be distal femur in the midline 2 to 3 centimeter above the external condyle. Now coming on to the procedure, how to do intraosseous cannulation. So we have to prepare the skin by alcohol followed by povidone iodine, and again cleaning with alcohol After that, we have to insert the needle through the skin in a screwing motion perpendicular to the bone and slightly away from the epiphyseal plate into the bone marrow cavity. Once we have reached the bone marrow cavity, there will be feeling of decreased resistance, which is known as feeling of giveaway. That means that we have reached bone marrow cavity, and to confirm that we have reached bone marrow cavity, we could either aspirate bone marrow, or we could give 5 ml or 20 ml, 5 ml normal saline bolus. If there is free flow of saline fluid, that means that we are in the bone marrow cavity and there is no swelling apparent. Once we have reached the bone marrow, we should secure the needle and start the infusion through manually through 20 ml syringe. Now coming on to the fluid therapy, we have to replace deficit fluid and we have to give maintenance fluid. So deficit fluid is basically the fluid lost prior to the medical care. It could be replaced either by crystalloid, which is preferred fluid, and if the patient is not responding to crystalloid alone, we could go for colloid fluid. Crystalloid include ringer lactate, normal saline or half normal saline, whereas colloid fluid include albumin, dextran or Hatta starch. For calculating maintenance fluid is given to replace insensible loss either through skin and respiratory epithelium. So to replace the maintenance fluid, we use Holiday-Sager method. By Holiday-Sager method, we could calculate the fluid requirement for 24 hours. So for initial 10 kilogram of weight, we have to give 100 ml per kg of fluid. For next 10 kg, that is for 10 to 20 kilogram of weight, we could we give 50 ml per kg of fluid. And for weight about 20 kilogram, we will give 20 ml per kg of fluid for every kilogram of weight. So as given in the example, if the child is of 22 kilogram of weight, so for initial 10 kilogram, we will give 1000 ml fluid. That is 10 into 100. For next 10 to 20 kg, we would give 50 ml per kg fluid, that is 500 ml. And for next 20 ml per kg, next 2 kg, we will give 20 ml per kg of fluid, that is 40 ml. So the total requirement for one day would be 1540 ml. Now, how to plan fluid therapy in different type of shock? So if the patient is presenting with hypovolemic shock, we will administer 20 ml per kg of fluid as a bolus in 5 to 10 minutes. And we could repeat as necessary. The amount of bolus that could be given depend on whether we have ICU care or not, that we will discuss in in subsequent slides. So if the patient is presenting with severe dehydration, so as we give in IMNCI guidelines, for patient of severe dehydration, we will give 100 ml per kg of fluid, which is to be divided into 30 ml per kg and 70 ml per kg. Depending on age of the child, the duration differs. If the child is less than 1 year of age, the initial 30 ml per kg of fluid is to be given in 1 hour, and the next 70 ml per kg of fluid is to be given in next 5 hours. Whereas if the child age is more than 1 year, initial 30 ml per kg of fluid is to be given in half an hour, and next 70 ml per kg of fluid is to be given in 2.5 hours. If the patient is having coming with significant blood loss, in that case we have to replace PRBC. So either PRBC could be given, which is preferred. If PRBC is not available, we could give 3 ml of fluid per unit per ml of blood loss. Albumin may be considered for additional IV volume. Albumin is a plasma expander, so it is especially helpful in case of shock which is not responding to crystalloid alone, and in case of trauma or burn patient. In case of cardiogenic shock, we have to look for signs and symptoms of fluid overload. If there is signs and symptoms of fluid overload, we have to start with diuretics and vasodilators. If there are no signs and symptoms of fluid overload and the patient is dehydrated, we will give small aliquots of fluid boluses over a longer period of time. So 5 to 10 per kg of fluid is to be given over 10 to 20 minutes. And we could give subsequent bolus according to requirement. In case of obstructive shock, we have to correct the cause of obstructive shock. If the patient is presenting with tension pneumothorax, we need to give we need to have needle thoracocentesis. In case of cardiac tamponade, pericardiocentesis has to be done. Few patients may have, especially septic shock patient may have more than one type of shock. So the septic shock may present with diarrhea and vomiting, leading to hypovolemic shock, or the patient may have additional features of myocarditis leading to cardiogenic shock, or the patient may have abnormal vasomotor tone leading to distributed type of warm shock. So the patient of septic shock may have more than one type of shock. Now coming on to the distributive shock, if the patient is presenting with septic shock, we should try to manage the patient in initial golden hour, as the prognosis is good if the patient is managed in initial golden hour, and the chances are more that the patient will ultimately, we could save the organs and the patient could be saved. As the time progresses, the chance of shock reversals deteriorates rapidly. So for initial management, as with any type of shock, we start with supplemental oxygen, we establish IO access. We initially start with fluid boluses of 20 ml per kg of isotonic saline, or if the patient is not responding to fluid, we could start with colloids. Up to 60 ml per kg of fluid could be given, or until the perfusion improves or the patient presents with signs of fluid overload. We have to correct any hypoglycemia, we have to correct hypocalcemia, we have to administer antibiotics within 1 hour, and we have to do serial lactate monitoring for see for the improvement in shock. In case of anaphylactic shock, the drug of choice is adrenaline, which is to be given IM, and we have to use fluid according to need. Neurogenic shock, in patient of neurogenic shock, 20 ml per kg of fluid boluses could be given over 5 to 10 minutes. If the patients, especially in the pediatric patients, as SAM is quite common in our country, the patient might present with severe acute malnutrition along with shock. So special consideration is to be given in patient with severe acute malnutrition. So in patient of severe acute malnutrition, we should not give any fluid boluses. The recommended fluid is 15 ml per kg, which is to be given over 1 hour, and we should monitor for respiratory rate and heart rate. If there is deterioration in respiratory rate, that is the patient respiratory rate is increasing by more than 5, and the heart rate is increasing by more than 15, that is there is clinical deterioration and we should stop fluid bolus. But if the patient is improving, that is the heart rate is decreasing and respiratory rate is responding, that means the patient is responding, and we could try an additional bolus. The fluid that could be given in patient of SAM could be either ringal lactate with 5% dextrose or N/2 saline with 5% dextrose. Now the amount of fluid that is to be given in patient of septic shock depends on whether we have ICU care available or we do not have ICU care. If we already have ICU care available, then we could give 40 to 60 ml per kg of fluid bolus with ICU care monitoring. That is, we could see for increase in tachycardia as well as ICU signs and symptoms of fluid overload. If ICU care is not available and the patient is not hypotensive, we should not give fluid boluses. If the patient is presenting with hypotension, we could give fluid bolus, but each fluid bolus could be up 10 to 20 ml per kg per bolus, and maximum fluid bolus that could be given without ICU care should be up to 40 ml per kg. Now, what are the goals we have to monitor and what we have to achieve in initial hour? We should have both central as well as peripheral pulses should be strong. Distal pulses should be equal to central pulses. Periphery should be warm. Capillary refill time should be less than 2 seconds. Mental status should be normal. Urine output should be more than 1 ml per kg per hour. And blood pressure should be above the hypotensive fifth centile levels that we have already discussed. Subsequent ICU goals that is to be achieved include normal serial lactate levels less than 2 millimole per liter. Target mean arterial pressure should be achieved. We should restore and maintain normal perfusion pressure, defined as mean arterial pressure minus the CVP, central venous pressure for age. SCVO2, that is central venous oxygen saturation, should be greater than 70%. Cardiac index, which is equal to cardiac output divided by body surface area, should be greater than 3.3 and should be less than 6 liter per minute per meter square. Coming on to the inotropic support, once the patient is not responding to fluid therapy alone, we have to start inotropic support. The initial inotrop of choice in cold shock is adrenaline, and if adrenaline is not available at our setting, then we could go for dopamine. In case of warm shock, as there is abnormal vasomotor tone and there is abnormal distribution of blood, so we prefer a potent vasopressor agent such as norepinephrine. Norepinephrine causes peripheral vasoconstriction, ultimately leading to redistribution of blood to more vital organs such as brain and heart. Now coming on to the different inotropes that are used. One of the most common inotrope that is used in PICU is adrenaline. Adrenaline stimulates all adrenergic receptors, including both alpha 1, alpha 2 receptors as well as beta 1 and beta 2 receptors. So due to effect on beta 1 receptors, it increases cardiac contractility. It also increases heart rate, and at lower levels, there is no significant effect on systemic vascular resistance, but at higher dose, more than 0.3 microgram per kg per minute, there will be increase in systemic vascular resistance as well. So adrenaline increases heart rate as well as cardiac contractility. At lower dose, it decreases systemic vascular resistance. So all these effects are beneficial in case of shock, as all these causes increase in cardiac output. But at higher doses, there will be increase in systemic vascular resistance, which ultimately lead to increase in afterload. Along with that, there is also increased myocardial oxygen demand. So both of these effects are detrimental. So we avoid adrenaline at higher doses. The dose that could be used is 0.05 to 1 microgram per kg per minute. Now, how do we prepare adrenaline infusion? Adrenaline vial comes with a concentration of 1 milligram per ml of ADR. So the amount of fluid ADR that is to be used is weight in kg in 0.3. This much milligram of adrenaline is to be mixed in 50 ml of 5% dextrose or 10% dextrose or normal saline. If this prepared solution is run at 1 ml per hour, that means it corresponds to 0.1 microgram per kg per minute of infusion rate. Now coming on to the second vasopressors, noradrenaline. Noradrenaline is a potent vasopressor, that is, it causes intense vasoconstriction. So due to intense vasoconstriction, it is particularly helpful in case of warm shock, as it causes redistribution of blood from less vital organs from skin and GI tract to more vital organs, brain and CNS. So both of these effects are beneficial, and so ultimately it leads to increase in systolic blood pressure as well as to diastolic blood pressure. It has minimal positive chronotropic effect, and at low doses it causes reflex bradycardia. So it is particularly advantageous in patients with intrinsic tachycardia. The dose that is to be used for noradrenaline includes 0.05 to 1 microgram per kg per minute. Now coming on to the dopamine, which is quite commonly used in older time, but today preferred medications for cold shock is adrenaline. So dopamine binds both to dopaminergic as well as adrenergic receptors. At lower doses, it activates dopaminergic receptors, which causes increased contractility with vasodilatation, mostly in renal and mesenteric bed. But at this dose, it doesn't have any significant effect on shock. So the dose preferred is above 5 microgram per kg per minute. So in patient of shock, we use 5 to 15 microgram per kg per minute of dose of dopamine. At this dose, the beta 1 effect of dopamine predominates, and due to beta 1 effect, there will be increase in cardiac contractility. Due to increased cardiac contractility, there will be increase in stroke volume. So due to increased stroke volume as well as increased heart rate, both these leads to increase in cardiac output, and due to vasoconstriction, so due to increased cardiac output, there will be increase in systolic blood pressure. There is minimal effect on diastolic blood pressure at low doses. But at higher doses, at more than 15 microgram per kg per minute, there is disproportionate vasoconstriction leading to increase in diastolic blood pressure. Although there will be increase in blood pressure of the patient, but there will be the chances will be that there is clinical deterioration of the patient due to increase in myocardial oxygen demand. So at higher doses, although there is increase in BP, but the cardiac output will fall, might fall, and there is also increase in cardiac oxygen consumption. So we usually avoid higher doses of most of the vasopressors. The dose for dopamine is 5 to 20 microgram per kg per minute. Coming on to the dobutamine. Dobutamine is a synthetic compound with predominant action over beta 1 as well as beta 2 receptors. Due to effect on beta 1, it increases cardiac contractility. So this leads to increase in stroke volume and ultimately to increase cardiac output. Due to beta 2 effect, it causes vasodilatation, which ultimately leads to decrease systemic vascular resistance and decrease in afterload. So it increases cardiac output and also it improves perfusion. But the BP may not increase substantially with dobutamine. Dobutamine is particularly helpful in case of cardiogenic shock, and it is a good choice in patient with poor perfusion with high systemic resistance due to vasoconstriction. So dopamine may be administered or added if in presence of myocardial dysfunction, so especially in cardiogenic shock, or if the patient is having persistent hypoperfusion despite achieving adequate intravascular volume and mean arterial pressure. So dose is again 5 to 20 microgram per kg per minute. So dose for ADR and NORAD both is 0.05 to 1 microgram per kg per minute, and dose for both DOPA and DOBUTA is 5 to 20 microgram per kg per minute. Now, if the patient is not responding to fluid alone and there is requirement of vasoactive substance such as adrenaline or NORAD or dopamine, that then we might consider stress dose corticosteroid in these patients. If the patient is having hemorrhagic shock leading to hypovolemia, or if the patient is anemic and hemoglobin is less than 7 gram per deciliter, then we might consider blood transfusion, especially if the hemoglobin is less than 7 gram per deciliter and the patient is is in shock. FFP transfusion is given in case the patient is having deranged coagulation profile, or if the patient is having any active bleeding, or if the patient is having delayed coagulation profile and we are planning for any surgical or invasive procedure. Prophylactic platelet transfusion is to be done only if the platelet count falls below 10,000. If there is no apparent bleeding, but there is significant risk of bleeding, then we may consider for platelet transfusion if the count is below 20,000 per millimeter cube. We might consider platelet transfusion below 50,000 if we are planning for any surgery or invasive procedure, or if the patient is having any active bleeding. Blood glucose level should be maintained below 180 milligram per deciliter. Antibiotics should be started within 1 hour. Diuretics may be used to reverse fluid overload once the patient's shock has been resolved. Deep vein prophylaxis is not routinely recommended, and we should give prophylaxis to prevent stress ulcers, and we should start enteral nutrition as early as possible. Monitoring a child with septic shock. So both there are clinical parameters that has to be monitored as well as biochemical parameters. So we should look for peripheral pulses, whether the pulses have normal volume, the patient is not having tachycardia. Once the patient has improved, capillary refill time should return to normal. There should be no signs of dehydration. We should look for signs of fluid overload, such as peripheral edema, hepatomegaly, raised JVP. We should look for heart rate and rhythm. Pulmonary and cardiac auscultations should be done, especially if the patient is having cardiogenic shock. In that case, bilateral basal cleft would be present. So improvement in bilateral basal clefts. Cardiac auscultation is especially important in case of pericardial effusion. Respiratory pattern, we have to look for respiratory pattern, whether the patient is having effortless tachypnea or tachypnea is associated with increased work of breathing. Urine output monitoring is to be done, which is a sign of internal organ perfusion. Mental status should improve with improvement in shock. Serial glucose monitoring in biochemical parameters, we have to look for glucose. The glucose level should be below 180. We have to correct any hypercalcemia. Lactate monitoring is to be done to look for improvement in perfusion. Electrolytes, blood, urea, nitrogen, creatinine, liver enzymes, these has to be done to look for multi-organ dysfunction. CBC has to be done if clinically necessary. Take home message from today's lecture is that we have to recognize the shock in initial compensated phase, as the chances of reversal of shock is best in case of compensated phase. As the shock progresses in decompensated phase to irreversible stage, the chances of reversal of shock is minimal. Fluid therapy is the mainstay of early treatment in case of septic shock and hypovolemic shock, and careful monitoring is required to assess the adequacy of fluid therapy. We have to also look for any signs of fluid overload. For warm shock, noradrenaline is the drug of choice, and for cold shock, adrenaline is the preferred vasoactive agent. These are my references, and thanks to all the contributors of today's lecture. Now, now I would like to invite our senior faculty, Dr. Nishant Verma, for presentation of ARDS. So, So good afternoon, everybody. I am Dr. Nishant. So after this talk on shock, managing shock in children, the next talk would be on managing ARDS with a special focus on COVID. We will be talking about general aspects of managing ARDS as well as how to manage severe COVID in children. As all of you know that ARDS is one of the most dreaded complications that can happen in COVID. So we need to know how to identify ARDS and how to manage ARDS in children. I hope I am audible to all of you. Okay. So the learning goals for the present seminar, present talk would be how to define pediatric ARDS, how to define severe COVID pneumonia in children, what lab evaluation should be done if we are suspecting severe COVID in a child, what pharmacological treatment needs to be done, what type of respiratory support is needed for managing these children, indications for mechanical ventilation in ARDS, and what ventilatory strategy is needed for managing ARDS due to COVID. This diagram here has been taken from the European Respiratory Journal from 2020, but very beautifully shows the clinical course of COVID-19 in any patient, be it child or an adult. So how the virus creates manifestations in a particular patient. Now the typical incubation period of this viral illness is around 5 days. And after this 5-day incubation period, the clinical features start to appear. And you can see that the viral load is maximum at the initiation of clinical pictures. So maximum viral load on day 0 of your illness. So if you want to use antivirals, they would be most effective if they are used in the initial phase of illness. As the duration of illness or the symptoms progresses, the viral load typically starts to decrease. So your antivirals will not be effective by the end of first week of illness. While the clinical features typically worsen as the days of illness progress, majority of patients, particularly children, have a self-limiting course, and within the day 7 of illness, they start to improve. But a small fraction may develop worsening of symptoms in the form of development of dyspnea by day 8. And if not managed properly, they may develop ARDS typically in the second week by around day 12. And this ARDS is also heralded by the inflammatory phase of illness, where the inflammatory markers would typically be on the higher side. The CRP, the ferritin, the dimers would be on the higher side. This is known as the pulmonary phase of illness, which happens in very small proportion of children. If the ARDS is managed properly, a significant proportion of these children may come out and will improve. However, around 30 to 40% of children with ARDS due to COVID-19, in spite of the best respiratory support, may not survive and may die. So we need to identify that which children may develop ARDS, how to manage them so that we can prevent their death. And it is very clear that antivirals may not have a very good role in managing these children because the viral load, once the ARDS is set in, is quite low. So it is the inflammatory reaction which is damaging the lungs and not as such the direct viral invasion. So how to define severe COVID-19 in children? As per the standard definition given by Indian Academy of Pediatrics, severe COVID is defined as pneumonia with any of the following: be it cyanosis, saturation of less than 90%, or increased respiratory effort in the form of grunting or severe retractions, presence of lethargy, somnolence, or seizures. So if any of these 4 are present in a child with pneumonia due to COVID, he would be categorized as suffering from severe COVID. Among this severe COVID, there is again an entity called as a child with critical disease. So if any of these 3 is present, it would be labeled as critical disease like ARDS, shock, or multi-organ dysfunction syndrome. So if any of these 3 is present, it would be labeled as critical disease. how common is severe COVID in children? So as I already told you that in adults, the proportion of those developing severe manifestation is much higher as compared to that in children. So for example, if 100 adults develop COVID infection, around 5 to 10% are likely to develop severe disease. While in children, this number from a systematic review of around 7,500 patients, it was found that only 2% develop severe disease and only 0.7% develop critical disease. So the number of adult children, the proportion of children getting sick because of COVID is much less than half as compared to adults. But still, because the population of India is so huge that if there is an outbreak, even 0.7% of this 0.7 proportion may translate into huge numbers. That is why it is better that we should be prepared to handle children with severe COVID-19. When to suspect ARDS in a child? So if you have any child who is developing progressive tachypnea, dyspnea, having tachycardia and auscultation, you find that there are diffuse bilateral crepitations or crackles. Child is getting severe acute confusion. He looks to have respiratory distress. He is cyanosed. There is diaphoresis. On X-ray, you find that there are bilateral infiltrates in the lung fields. There is declining oxygen saturation and increasing oxygen requirement. Then you should suspect that child may be developing ARDS. In adults, we classically find what is known as silent hypoxia or happy hypoxia, where although the saturations are going down, but that adult does not have so many clinical manifestations, he may not appear distressed. But this silent or happy hypoxia is less common, particularly in younger children. It may be seen in adolescents. So younger kids, they will manifest clinical features, while adults may just have silent or happy hypoxia. Clinical features of cough, chest pain, wheezing, hemoptysis, and fever are inconsistent and may not be there in all children where ARDS is developing. So for defining ARDS in children, there are certain requirements, certain investigations and lab values which you need to calculate so that you can fulfill the definition of ARDS. Now, what are these things? You need at least a chest X-ray. You need oxygen parameters from the ABG like saturation and PaO2. So for PaO2, which is partial pressure of arterial oxygen, and ABG is must. Saturation can be seen from the pulse oximeter and can also be seen from the ABG. So saturation, for measuring saturation, and ABG is not mandatory. But for PaO2, pH and PCO2, ABG is mandatory. You also need to have certain parameters from the oxygenation device which you are using, like you need an FiO2, you need the mean airway pressure. Most of the modern day ventilators give the value of mean airway pressure which that ventilator is delivering. From these values, you need to calculate certain parameters. These parameters include the PF ratio, which is nothing but dividing PaO2 by FiO2. This gives you the PF ratio. SF ratio is saturation divided by FiO2. Oxygenation index is FiO2 into mean airway pressure into 100 divided by PaO2. And oxygen saturation index is FiO2 into MAP into 100 divided by SpO2. So these four values are needed to identify or diagnose ARDS and to categorize the severity of pediatric ARDS. So for defining ARDS, this definition has been given by the Pediatric ALI committee and was published in the Pediatric PCCM journal in 2015. So age of a child, you must exclude children with perinatal related lung disease, so which means children with bronchopulmonary dysplasia must be excluded from this definition. The disease should be of short duration, so it should happen within 7 days of a known clinical insult. The respiratory failure should not be because of cardiac or fluid overload, cardiac failure or fluid overload. And on imaging, you should have new bilateral infiltrates which are consistent with acute lung parenchymal disease. So all these four things should be met. And then you must meet the oxygenation criteria for defining ARDS. If a child is on non-invasive ventilation, Then if he needs a CPAP of more than 5 centimeters with a PF ratio of less than 300 or a SF ratio of 264, then he would be labeled as ARDS. A child on invasive mechanical ventilation, on the basis of oxygen index or oxygen saturation index, you can categorize him as mild, moderate, or severe if his oxygenation index is 4 to 8 or OSI between 5 to 7. And similarly, with higher values, the severity is categorized as moderate and severe. Now, this definition may not be very important for initiating treatment, but once you have a child with ARDS, a given patient you are managing with your treatment protocol, then for subsequent follow-up visits on day 2, day 3, you can calculate these values and you get to know whether the child's ARDS is improving or deteriorating. So that is why these values should be calculated on a daily basis in all children with ARDS to monitor their improvement or deterioration. Another entity is at risk of pediatric ARDS. It is nothing but children who are not fulfilling the criteria of ARDS at present, but still need oxygen, so they are at risk of pediatric ARDS. So any child on nasal mask, CPAP or BiPAP who requires an FiO2 of greater than 40% to maintain his saturations, he is at risk of ARDS. A child who is on oxygen by face mask, cannula or high flow, who needs high flow oxygen. So for defining flow, you at different age, you have different cutoff. So if a child is requiring oxygen flow, which is greater than these values, he is again at risk of developing ARDS. And the child who is on invasive mechanical ventilation, who needs oxygen to maintain saturation, but at present is not fulfilling the criteria of ARDS, all these children are at risk of pediatric ARDS, and they have to be monitored very closely, because if they develop ARDS, then their ventilatory strategies need to be optimized. Now, coming to how to manage severe COVID pneumonia and ARDS in children. This was about diagnosis. Now coming to management. So management, you have to do certain lab evaluation. So lab evaluation, the basic parameters like a complete blood count, a baseline liver and kidney function test, inflammatory markers like CRP, D-dimer, ferritin and procalcitonin, an arterial blood gas, and a chest X-ray. So this is a bare minimum which you must do in all children with severe COVID-19. And these investigations, you may need to repeat them every 1 to 2 days, depending on the child's clinical condition. Investigations like ABG you may sometimes need to perform an ABG multiple times in a day as per the child's need. Now coming to X-ray, you already have had a class on day 1 on X-ray. So X-ray, you can, for reading an X-ray, you need to divide the lung fields into 4 or 6 zones, and you try to find which zones are abnormal. The typical findings are multifocal, bilateral, peripheral opacities with rounded morphology. Predominantly, the lower zones of lungs are affected. And even on an X-ray, you can categorize the severity of lung disease as mild, moderate, and severe. If only 1 or 2 zones are affected, it would be mild. If 3 to 4 zones are affected out of 6, it is moderate. And if more than 4 zones are affected, it would be categorized as severe COVID-related radiological disease. Now, this is a X-ray from a patient who was admitted with severe COVID in our PICU last year. And you can clearly see that at least 5 zones are affected. So if you draw an imaginary line here and then divide the lung into 6 zones, you can clearly see that this, and this zones are affected. So 5 out of 6 zones are clearly affected. So this child has a severe COVID-related lung injury. Another imaging modality that has gained recently much importance is HRCT. But let me state very clearly that HRCT is not indicated routinely in severe COVID. You don't need to subject all your patients to an HRCT. For doing an HRCT, a patient must be hemodynamically stable. So you cannot shift a sick patient for a CT because such a child may deteriorate during transport or during the procedure. The child must not be on high ventilatory settings, must not be on high flow nasal cannula or an IV, because these devices cannot be used during transport. Child may deteriorate. And CT may be useful only if you have a high suspicion of COVID, but RT-PCR is negative. Then radiological diagnosis on an HRCT can guide your management. Or if the child is showing unusual clinical course, unusual X-ray picture. So if you have a child where you have diagnosed COVID, you have started treatment, but the child is not responding the way he or she should, or on X-ray you are finding certain atypical features, you are suspecting fungal pneumonia, then in such cases, doing an HRCT may be useful. Common CT findings on an X-ray, on a CT in COVID is ground glass opacities, consolidation with a bilateral peripheral distribution, predominantly affecting the lower lung lobes. Coming to ABG, so ABG in a child with ARDS shows hypoxemia along with an elevated arterial alveolar oxygen gradient, or AADO2. So hypoxemia with this is seen. And initially there is, because of the increased respiratory drive, there is CO2 washout leading to acute respiratory alkalosis. But if the child is developing CO2 retention, this is an ominous sign. It indicates that the child is developing exhaustion. He is not able to ventilate properly, so CO2 retention is happening. So respiratory acidosis is an ominous sign, and it is an indication for starting mechanical ventilation. If a child is showing metabolic acidosis, it represents that probably such a patient is having septic shock or associated acute kidney injury or hypoxemia. So clinical monitoring along with serial ABG is important while managing any child with ARDS. After doing your basic lab workup and radiological workup, you come to the treatment. So all children with severe COVID-19 must be admitted in your PICU. They cannot be managed in the general ward. They have to be admitted in PICU. You need to provide optimum respiratory support, which you will see in subsequent slides. What do I mean by optimum? You have to start certain pharmacological treatments, steroids with or without remdesivir, empirical antibiotics, and a restrictive fluid therapy, because overzealous administration of fluid can lead to cardiac failure and pulmonary edema. So restrictive fluid therapy should be used. Now this diagram has been taken from the Ministry of Health and Family Welfare Guidelines of April 2021 about treatment of severe COVID-19 in children. These are the pharmacological therapy which are recommended. First is the antiviral remdesivir. Now again, I showed you in the first slide that remdesivir is an antiviral and it will be effective only it is used when the viral load is high. So that is the initial days of illness. While ARDS and severe COVID typically manifest in the second week of illness. So remdesivir is not a miracle drug. It may not be of very good value in such patients. So that is why its use has been now restricted. If you want to use it only in the initial 10 days of onset of symptoms. Beyond 10th day, it is of no use. At present, it is not recommended by the DGHS in children less than 18 years of age. So if you want to use it in such a in children less than 18 years, take permission from your hospital authorities and then use it. The dosing which is recommended is 3.5 to 40 kg. It is 5 mg per kg on day 1. And on subsequent 4 days, it is 2.5 mg per kg. For those who are above 40 kg, the dose is similar to adult dose, that is 200 mg on day 1 and 100 mg from day 2 to day 5. It is contraindicated if the liver enzymes are more than 5 times upper limit of normal, or if the creatinine clearance is less than 30 ml per minute. So a baseline liver and kidney function test are must before administering remdesivir. The next drug, which is the cornerstone of managing pharmacological treatment of severe COVID, is steroid. Because inflammation is the main driving factor for lung injury in COVID. So anti-inflammatory steroids are the most potent ones. So we have to use either dexamethasone or methylprednisolone. So if you want to use dexa, the dose would be 0.15 mg per kg per dose twice daily. Methylprednisolone, the dose would be 0.5 to 1 mg per kg twice daily. And this dose has to be used for 5 to 14 days, depending on the continuous clinical assessment. If the child improves dramatically in 2 days, then you may not need it to give it for the entire 14 days. You can give it for 3-4 days and taper it off over the next 2-3 days. However, if the child remains sick, the inflammatory markers are quite high, you may have to give it for a longer duration for 14 days and then gradual tapering. Next is use of antimicrobials. Now again, COVID is a viral disease, so antimicrobials are not going to cure a child of COVID, but because bacterial superinfection may be associated, it is very difficult to differentiate fever is whether of purely viral origin or there is bacterial co-infections. That is why broad spectrum antimicrobials is recommended in severe COVID-19. You can choose either amoxicillin or amoxiclavulanic acid or ceftriaxone, but I would suggest do not start with something like piperacillin tazobactam or vancomycin or teicoplanin or carbapenems. These are reserved drugs, should be reserved only once a patient you are suspecting bacterial pneumonia or suspecting hospital acquired or ventilator acquired pneumonia. Don't start them from day one in a child with severe COVID-19. Now coming to the respiratory support for severe COVID, the options which are available to you are nasal prongs, simple face mask, a non-rebreathing mask. You can also use high flow nasal cannula or high flow nasal oxygen, NIV or the CPAP, and invasive mechanical ventilation. So these are the options which you can use in your PICU for providing respiratory support. The target saturation which we aim is during resuscitation a saturation of above 94%. And once you have stabilized the child, you can accept anything which is above 90%. So you don't need to escalate your treatment if the saturation is between 91-92%. Escalate it in a stable patient only if saturation is persistently going below 90%. You can consider using the awake prone positioning in older children. Maintaining a young patient in prone position is very, very difficult. Sometimes you may not have caregivers or continuous monitoring if the patient is lying prone. There's a risk of aspiration, there's a risk of sudden infant death. So I would not recommend using prone positioning routinely in younger children, but for older children, for adolescents, prone positioning can be considered. Now coming to management of ARDS in COVID, if you have a child with mild ARDS, the target saturation is 92 to 97%, while for moderate to severe ARDS, the target saturation is 88 to 92%. This means this is known as permissive hypoxemia. So in severe COVID-19, if we aim to achieve high saturations, you are at risk of causing ventilator-induced lung injury. So that is why even lower saturations are acceptable in severe ARDS. While for mild ARDS, saturation between 92 to 97% should be aimed for. And for mild ARDS, we begin with NIV or high flow nasal cannula. And if it fails, then you consider intubation and mechanical ventilation. While for moderate and severe ARDS, intubation and mechanical ventilation are needed. This diagram shows you the stepwise escalation of respiratory support for managing hypoxia in COVID. For children who are unable to maintain saturation on room air, for children who are having tachypnea, so any child with severe COVID-19, you initially start your management with nasal prongs. So nasal prongs, children are very comfortable using nasal prongs. They are still able to eat and swallow when the child is on nasal prongs. But the limitation is it cannot provide FiO2 beyond 45%. So if a child needs low FiO2s, you can use nasal prong at a flow rate of between 1 to 6 liters per minute. A child who is hypoxic on nasal prong, you can escalate to a simple face mask or to a non-rebreathing mask, and you can achieve FiO2 of up to 95% using a non-rebreathing mask. A child who is having respiratory distress or hypoxemia persisting on this device, you can escalate to high flow nasal cannula or a non-invasive ventilation. High flow nasal cannula is more, children are more comfortable with high HFNC than with NIV. NIV is much more painful, and using NIV for prolonged periods is difficult in children. So HFNC can be tried. Short periods of NIV can be tried. If both of them are failing, then you would need to start invasive mechanical ventilation by intubating the child. So indications for intubation and mechanical ventilation in severe COVID would be a child who is having severe respiratory distress, is going into respiratory failure, is getting exhaustion, the CO2s are rising. So in such a patient, you would have to intubate. If a child's GCS is falling, so a child would set with a GCS of less than 8, the airway would be threatened. So in such a patient, you would have to consider intubation. If the saturation is persistently below 85% despite use of NIV, BiPAP, HFNC or NRM, then again you would have to consider intubation. A child with severe ARDS and a child where you have respiratory acidosis. So if there is rise of CO2 with acidosis, then you can consider using NIV or BiPAP, and if the acidosis is persisting despite NIV, then you will have to consider intubation. So this acidosis must be respiratory. I'm not talking about metabolic acidosis. Metabolic acidosis is not an indication for intubation. It is respiratory acidosis which is an indication. Coming to mechanical ventilation for a child with ARDS, just a brief revision of what was taught in your previous day's lecture on mechanical ventilation. So whenever you have to ventilate a child, you have to be very well versed with your machine which is there in your ICU. Whenever you ventilate, you set two types of variable. One is control variable, the other is phase variable. The control variable means in what way the breath is going to be delivered. So in other words, what आप क्या control करने वाले हैं, whether the breath is being delivered in pressure mode or volume mode. So two basic types of control variables are there, pressure or volume. Certain ventilators also have a flow control, but we would be focusing on pressure and volume. Then there is phase variable. Phase variable means how will the fine tuning of that breath be done. So fine tuning को हम phase variable बोलते हैं. There are four basic types of phase variables. One is trigger. Trigger means how a breath would be initiated, how the ventilator would know when to start. Next is limit. Limit means till what value the breath would be, positive breath would be delivered. It can either be pressure limited, it can be volume limited, it can be flow limited. So this is limit. And then it is cycling. Cycling means when should the inspiration stop. So cycling means when should the ventilator cycle from inspiration to expiration. Most of the controlled breaths are time cycle. So after a particular TI, the ventilator cycles from inspiration to expiration. And fourth variable is the baseline variable, which is PEEP. So at baseline, when the ventilator is not delivering a breath, what value has to be maintained? So that is PEEP. So control variable, you can use either pressure or volume, whichever you are familiar with. So both of the modes, both of the control variables have certain advantages as well as disadvantages. You can choose either one, whichever you are more comfortable with. So either choose pressure or volume, choose whatever you want. The initial mode which you would start is SIMV or assist control. So these are the two initial modes which you can choose. Choose either SIMV or assist control. Now, what is the difference between these two modes? So this is a scalar diagram, flow scalar of assist control mode, and this is the SIMV mode. By scalar we mean on x-axis is time. So this is time, and this is flow. Okay. So whenever in an assist control mode, whenever a patient initiates a breath, whole breath is delivered. So patient को just initiate करना है. जितनी बार भी patient initiate करेगा, उतनी बार ventilator is going to deliver a breath. So you can see all these 1, 2, 3, 4, 5. The patient has just triggered and ventilator has taken over and given the entire breath. So this is assist control mode. If the patient is not breathing, then there is a set backup rate जिसपे ventilator उतनी breaths कम से कम deliver करेगा. On the other hand, in SIMV mode, which is synchronized intermittent mandatory ventilation, patient would be triggering this, and this, but not all breaths would be controlled. Only you can see this and these two breaths are controlled. So this remaining breaths are not controlled. So in SIMV mode, jitni aap respiratory rate set karenge, only those many breaths would be controlled. The remaining breaths, the ventilator is going to allow the patient to take. So explaining you by an example. Now suppose you set a respiratory rate of 20. Okay, respiratory rate of 20. And the patient is breathing at a rate of 40. So in assist control mode, all the 40 breaths would be controlled by ventilator. While in SIMV mode, only 20 breaths would be controlled by the ventilator. Remaining 20 breaths, patients would be taking on his or on her own. Ventilator is not going to touch those breaths. So in assist control mode, clearly the work of breathing would decrease more. So assist control mode से work of breathing बहुत ज़्यादा कम हो जाएगी, but there is a risk of hyperventilation क्योंकि सारे breaths control पे patient को ventilator support करेगा, control करेगा. So there is a risk of hyperventilation and CO2 washout, जो कि SIMV में नहीं है, but the work of breathing is going to be much reduced in assist control mode of ventilation. There is a hybrid mode which is known as SIMV plus pressure support. So in SIMV, what was happening was 20 breaths control कर लिए, बाकी 20 को patient के लिए छोड़ दिया. But in 20 को patient पे छोड़ना was not the right thing to do. So what SIMV plus pressure support does is the remaining spontaneous breaths are given a pressure support. So this pressure support, so these are the spontaneous breaths. These are the spontaneous breaths. Now ventilator is going to support them by some amount of pressure. They will not be controlled. So सारा control नहीं होगा, but some support can be there. So the work of breathing would decrease. So majority of the ventilators which are available like the Dragger, the PM cares, have this SIMV plus pressure support, which is a hybrid mode. And it can also be used as the initial mode for ventilating a child with ARDS. The next mode, which is again very commonly used, is CPAP plus PSP. But this is a spontaneous mode and should never be used as the initial mode of ARDS. This is always used as a weaning mode. This is a weaning mode because इसमें सारा काम patient को करना है. Ventilator is just going to support the patient's breath. It is not going to control a patient's breath. So this is a weaning mode. Should not be used as initial mode in ARDS. So coming to the initial settings which we are going to use. So mode you can use either pressure or volume SIMV, or pressure or volume assist control. You can use whatever you are comfortable with. You start with a low tidal volume. You start with a tidal volume of 6 ml per kg. If you are using the volume mode, you can set tidal volume. If you are using the pressure mode, start with a PIP of 20 to 22 centimeters of water. Set a PEEP which is slightly higher because child has ARDS, you want to improve oxygenation. So set a PEEP of around 8 to 10 and titrate this PEEP upwards if your saturation is not achieved, target saturation is not achieved. Start with a FiO2 100%, and once your target saturation is achieved, gradually reduce your FiO2 first. Respiratory rate and inspiratory time has to be set as per the physiological age limits. Always prefer using a cuffed endotracheal tube while you are ventilating a child with ARDS because leaks are minimized, so you would be able to achieve maximum mean airway pressure if you are using a cuffed endotracheal tube. Now, once after starting the patient on initial settings, the subsequent modification would be done based on your subsequent monitoring of the child. If the oxygenation is not achieved, then you have to make certain changes in your ventilator setting. The most effective strategy for improving oxygenation is increasing the PEEP or positive end expiratory pressure. So if you increase the positive end expiratory pressure, the area under this mean airway pressure curve would increase, so the oxygenation would improve. You can also increase the PIP or tidal volume, but that would increase the chances of developing barotrauma. You can increase TI to a certain limit. You can increase the IE ratio to a certain limit, but all these are, you cannot go beyond a certain limit because physiological values को आप बहुत ज़्यादा छेड़ नहीं सकते हैं. What you can do is increase positive end expiratory pressure, which is the most effective strategy for improving oxygenation. If a child is developing CO2 elimination, you can either increase the tidal volume or increase the respiratory rate because CO2 elimination is directly proportional to minute ventilation, which is a product of tidal volume and respiratory rate. Whenever ventilating a child with ARDS, allow for a certain amount of CO2 retention. This is known as permissive hypercapnia. So as long as the pH is above 7.2, you should accept high CO2 values. So CO2 55, 60, anything is acceptable जब तक कि pH is above 7.2. If a child is having
pH below 7.2, then you cannot accept high CO2 values. You will have to change your ventilator settings, increase child volume so that CO2 washout happens. Sedation and analgesia are very important when you are ventilating a child with ARDS. This ensures that your child will tolerate mechanical ventilation properly. Agar aap nahi use karenge, then patient is going to fight. Patient is going to be in a lot of pain. Pain would increase oxygen demand of the child, would worsen child's hemodynamic status. So child should be calm and pain-free. So use midazolam with or without fentanyl. Midazolam is for sedation. Fenta is for analgesia. Midaz is used in a dose of 1 to 2 mics per kg per minute, and it has to be titrated up or down as per the child's need. And fentanyl is used in a dose of 0.5 to 2 microgram per kg per hour, and you have to titrate its dose to achieve the desired effect. Neuromuscular blockade with vecuronium is not indicated routinely, okay? But there are certain instances if a child is not getting sedated, you are not able to improve his oxygenation, then you may need to paralyze certain patients, especially older kids, by using a muscle relaxant, but it is not routinely indicated. So consider it only if sedation alone is inadequate to achieve the effective mechanical ventilation. Now, when do we transfuse a child who is in ARDS? So the routine PRBC transfusion is indicated only if the hemoglobin is below 7. If hemoglobin above 7, PRBC transfusion is not indicated. However, if a child has unstable septic shock, then you have to maintain a hemoglobin of above 10. So jab bhi 10 se kam ho, unstable septic shock may transfuse. No septic shock, below 7, then transfuse. Ventilating a patient in prone position, again, it's a difficult and tedious job. You can try prone ventilation in 12 to 18 years. In younger kids, there is no evidence to support routine use of prone ventilation. So in older kids, 12 to 18 years, you can try. But whenever you are ventilating a child in prone position, be very careful that all the lines are connected. Someone is monitoring the saturation, the heart rate must be very carefully monitored, because accidental disconnection may happen and you may lose such a patient. So be very receptive to all the alarms. What to monitor in a child with ARDS? So the most important thing is clinical monitoring. So whether the child is improving or not, you have to monitor his clinical status. Monitor his heart rate, his respiratory rate, his blood pressure, his saturations, his consciousness, his urine output. All these things need to be recorded every 1 to 2 hourly on a vitals chart, which should be placed at the bedside. Lab monitoring, ABG, you may need to do ABG in a child with severe ARDS 1 to 2 times in a day on an SOS basis. While doing an ABG, you have to aim for adequate, not normal gases, because if you aim for normal gases, normal ho jaye PO2, SO2, PCO2, then you will land up over-ventilating a child. Over-ventilation, risk of ventilator-induced lung injury. So just achieve for adequate, don't achieve for ideal. Chest X-ray, again, it may be needed on an SOS basis. So one thing is, in patients who are on high ventilatory settings, they're always at risk of developing a pneumothorax. So if you suspect pneumothorax in a child with ARDS, your diagnosis has to be clinical. You cannot wait for X-ray confirmation, because जब patient इतनी ज़्यादा ventilated settings पे है, अगर उसको pneumothorax होगा, there are very, very high chances that he would develop tension pneumothorax. And if you miss diagnosis of tension pneumothorax, within no time, child would develop cardiogenic shock. So diagnosis of pneumothorax has to be clinical. So when you examine a child, अगर air entry एक side reduced है, lung chest movements एक side कम है, percussion में resonant note आ रहा है, then your diagnosis is pneumothorax. Manage him as pneumothorax. Do a needle drainage under water seal. और जब X-ray available होगा, आप उसको confirm करिए. But don't wait for X-ray confirmation for doing any intervention. Inflammatory markers like CRP, ferritin, D-dimers, they may again be needed in a child with severe COVID pneumonia on every 24 to 48 hours to know whether steroids have to be increased, whether antibiotics have to be upgraded. So all this information you can get by doing the inflammatory markers. Then ventilatory monitoring, again, monitor the chest rise, retractions in a child, monitor the plateau pressure in your ventilator. You should aim to keep the plateau pressures below 30 centimeters of water, because beyond 30 centimeters of water, the plateau pressure, if it goes beyond this, then the risk of barotrauma again increases. Monitor the minute volume very carefully and set the alarm limits properly, क्योंकि ऐसा नहीं होना चाहिए कि आपके PICU में वेंटिलेटर का अलार्म हमेशा बजता रहे. Okay, if you set your alarm limits properly, तब अलार्म तभी बजेगा जब actually abnormal values आएंगे. So set your alarm limits, and once there is an alarm, go and address why the alarm is flaring, and then do the adequate corrective steps, and then the alarm should go off. Avoid frequent circuit disconnection. So you have seen that children with ARDS, you have to recruit the lungs by keeping the PEEP at higher values. We have kept the alveoli in an open state. If you disconnect the circuits, so all the alveoli would collapse. तो जब उनको वापस रिक्रूट करना होगा, अगेन सारे प्रेशर्स आपको बढ़ाने पड़ेंगे. So avoid frequent circuit disconnection. And one of the most common reasons for circuit disconnection is you बार-बार suction करना. So there is no need to suction the patient routinely. Suction आप तभी करेंगे when you are seeing visible secretions in the ET tube, or child is having hypoxia and you think that the ET tube is blocked. Alarm limits में आपको आ रहा है कि ट्यूब ब्लॉक का अलार्म आ रहा है या पीक प्रेशर बहुत ज्यादा आ रहे हैं, then you are suspecting that there may be ET block, then you do a suction. अगर inline suction catheters available हैं, then you should always use such catheters because they do not need circuit disconnection for doing the suction manner. Assess the sedation adequacy daily. You should give a daily sedation holiday of 1 hour to monitor the child's sensorium. Okay, daily sedation holiday morning के time में जब staff अच्छे से होता है, तो break the sedation for 1 hour and assess कि बच्चे की sensorium कैसी है. So we would conclude by going through a case scenario of ARDS in a child with COVID-19. So we had a 6-year girl who weighs 15 kg, who was COVID positive. The child came to our emergency department and they gave her a history that she was unwell for 7 days with fever, cough, and progressive respiratory distress. When you examine the child, she was agitated. Her airway was clear. She was conscious, but she had severe respiratory distress. Her saturations on the pulse oximeters were 84%, despite using a high flow nasal oxygen of 30 liters per minute and an FiO2 of 100%. So this is the maximum permissible support for a 6-year-old. So flow of 30 liters, FiO2 of 100%, and on that support, her saturation is below 84%. She has tachycardia. Her blood pressures are normal. Peripheries are warm, so may not be in shock. We also had an ABG which showed that pH is normal. CO2 is washed. Their pH is on the alkalosis side. There is certain amount of CO2 washout, and there is hypoxemia. So she has acute respiratory alkalosis with hypoxemia. This is the X-ray. You can clearly see if you divide it into 6 zones. And so all the lung zones are affected. So 6 by 6 grading by the X-ray, severe COVID-19, severe hypoxemia, failing the non-invasive support. So you have to consider mechanical ventilation. You can try non-invasive ventilation, but because the child was so agitated, we directly decided that we should consider intubation. So whenever you are intubating a child, always follow the rapid sequence intubation, which was taught to you yesterday. So just sedate her, pre-oxygenate her, and using a cuffed tube after proper sedation, intubate the child and connect her to your mechanical ventilation. So once we have decided to ventilate this child, she has ARDS, we can use either volume or SIMV or assist control. If you want to use pressure mode, you can also use pressure SIMV or pressure assist control. So we decided to use volume assist control. Tidal volume already discussed, 6 ml per kg. So 15 kg weight, 15 to 6, 90 ml tidal volume was started. PEEP thoda sa zyada rakhna hai, so started with a PEEP of 8. Physiological respiratory rate of 20, physiological TI of 0.8 second, and 100% FiO2 say we have started this child on mechanical ventilation. And along with these initial settings, we have to use a good sedation, good amount of analgesia with or without muscle relaxant. This patient stabilized on these settings. So volume assist control mode, because hypoxemia improved नहीं हो रही थी, हम लोगों ने gradually PEEP को escalate किया till we reach the peak of 16. So हमने 8 से start किया था और gradually increase करके 16 पे पहुंचे, and then this child's oxygenation improved, and after that we gradually reduced the FiO2, and now this child is on FiO2 of 60% of PEEP of 16, tidal volume of 90, and this child is able to maintain her saturations, and we are monitoring the plateau pressures, and plateau pressures are being maintained at less than 30. So once this child has stabilized, we have to wean this child. So weaning again कल already discuss हुआ है. So इस patient को जब हमें wean करना होगा, तो हम पहले तो अगर इस FiO2 पे और इन settings पे maintain कर रहा है, तो हम PEEP को gradually कम करना start करेंगे. Because PEEP of 16 is very high. Initially जरूरत पड़ी थी, अगर patient अब 1-2 दिन से सही है, तो हम PEEP को gradually reduce करना शुरू करेंगे. We'll decrease from 16 to 14, then 12, then 10, then 8. जब 8 पे भी मेंटेन करने लगेगा, then we may consider reducing the respiratory rate. जो 20 है, हम सपोर्ट कम करने के लिए 20 से 18 करेंगे, then 16 करेंगे, then 14 करेंगे, 12 करेंगे. मोड जो वॉल्यूम असिस्ट कंट्रोल पे है, हम उसको SIMV पे स्विच करेंगे, बिकॉज SIM असिस्ट कंट्रोल में ऑलरेडी आई टोल्ड यू दैट रेट आप कुछ भी सेट करें, वेंटिलेटर जितनी बार भी पेशेंट ब्रीथ करेगा उतना सपोर्ट करेगा. So this cannot be used as a weaning mode. We will shift her to SIMV, and then we can shift, अगर वो tolerate करेगी, we'll shift her to CPAP mode, और वो भी अगर tolerate करेगा, we'll give a spontaneous breathing trial, and if the patient passes the spontaneous breathing trial, we'll extubate such a child. So just to summarize the management, again, this has been taken from the Ministry of Health and Family Welfare. A child with severe COVID pneumonia, if fulfilling any of these criteria, it would be labeled as severe COVID. Admit in ICU, evaluate for all the critical signs like ARDS, septic shock, multi-organ dysfunction. Use your pharmacological treatment, steroids with or without remdesivir, empirical broad spectrum antibiotics, oxygen therapy as per the child's need. Gradually escalate the oxygen therapy if the child is not maintaining here oxygen saturations. If develops ARDS, mild ARDS, HFNO or NIV, severe ARDS, moderate ARDS, mechanical ventilation with a low tidal volume strategy, good amount of sedation. So the take home message from the presentation would be, while managing child with severe COVID, focus on the basics. Okay, focus on basic mechanical ventilation, infection prevention, nutrition. Okay, these are your cornerstones of managing any sick child in your PICU. Steroids, remdesivir, low molecular weight heparin, nothing is a miracle. Right patient, right time will do the trick. Okay, you should not believe too much on these drugs. It is the basics which are going to save your child. Ventilation is a blend of art and science. Spend time with the patient and the machine. So जब patient machine पे नहीं है, टेस्ट लगा के आप मशीन पे टाइम स्पेंड करिए, एक वैल्यूज देखिए कि कैसे पैरामीटर्स चेंज करते हैं, क्या क्या अलार्म लिमिट सेट होता है. हर वेंटिलेटर्स के साथ एक मैनुअल आती है, एंड मैनुअल हैज extremely good information about your machine. So go through the manual, go through the modes in your ventilator. When you ventilate a child, ventilate gently with low tidal volumes, because if you increase tidal volume, there is a risk of barotrauma. Aim for acceptable, not normal, not ideal. So if you aim for ideal and normal, तो over ventilation होगा, ventilator induced lung injury होगी. So जो acceptable है उसी से satisfied रहें. And all said and done, ARDS, severe COVID may have poor outcomes. So communicate with the relatives. बहुत ही clear picture उनको दीजिए कि patient की current status क्या है, what you are doing, what management you have started. So everything should be made very, very clear to the families of such patients so that they are able to cope up with whatever the outcome may be. So these are the references which I have used for my presentation. You can go through them, and I would like to thank all the contributors for this presentation. If you have any questions, you can type in the chat box or contact me on my email. Thank you.
Thank you very much, sir, for this warm, lucid and informative talk. So there is a question for you. For how much duration FiO2 100% can be given without causing oxygen toxicity?
Okay, so if you are talking about ventilating a child, so you start with 100%, start with a good PEEP. If a child is maintaining his saturation of, say, above 94%, you would start reducing the FiO2. Okay, FiO2 100% will not cause toxicity. It is the high oxygen levels in the blood that will cause toxicity. So you are going to monitor the saturations. And that's what I said. Don't aim for a saturation of 100%. आपको 100% saturation कभी नहीं रखना है. 94% से ज्यादा जैसे ही हो जाएगा आप FiO2 कम करना शुरू कर देंगे. Newborns are much more susceptible to oxygen as compared to older children. So oxygen से उतनी injury तो नहीं होगी, but still you would be causing overventilation. So जैसे ही 94% से ऊपर जा रहा है, settings और FiO2 gradually कम करना शुरू करेंगे.
Thank you very much, sir, for these practical tips. So we are going to have a 20-minute lunch break. And after the lunch break, we are going to join, going to have a lecture on MISC diagnosis and management by Dr. Aisha Ahmed. She is from Aligarh, AMU. So we are going to have 20 minutes break. So we will join again at 2 p.m. Thank you very much. Till then.
I welcome you all back in the post-lunch session. And myself, Dr. Arisha Alam, I'm Assistant Professor in Pediatrics in KGMU. Let's move ahead with the next talk, which is going to be delivered by Dr. Aisha Ahmed. She's a faculty from Aligarh Muslim University. She will be talking about multi-system inflammatory syndrome in children, diagnosis and management. Over to Dr. Aisha.
Okay, thank you, Isha. Thank you so much. Am I audible? Can you hear me?
Yes, you are audible.
Okay, so can you see the slides as well?
Yeah, the slides are.
Okay, so thank you for a nice introduction. So I welcome you all to this post-lunch session on multi-system inflammatory syndrome in children. So till now you have been taught about, and there have been discussions about what happens during COVID. Now this is something which does not happen with COVID, but it can happen as late as few weeks after COVID. And we have seen a lot of cases. There was an outbreak of MISC children in the last a few months. So this is one thing which happens after COVID, and because we are not accustomed to seeing such children, so there was a lot of confusion about what these MISC is and what are the children whom we suspect to be a case of MISC. So this is something which will be a topic of discussion today. So in the next 25 to 30 minutes, I would try to take you all through the following learning objectives. So when the session ends, I expect all of you to have some idea about when to suspect a child as a case of MIS. What are the clinical features? What are the how to evaluate a case, how to investigate a case, and how to manage a case who is proven to be a case of MIS subsequently. So coming to the first part, what actually is MIS? So as the name implies, multi-system inflammatory syndrome. So it's rather than inflammatory, it's something which is hyperinflammatory, as I'll come to it in a short while. So it is a multi-system and hyperinflammatory syndrome that follows exposure to SARS-CoV infection by 2 to 4 weeks and affects children and adolescents. So what qualifies, what are the pointers that it's a multi-system? That means more than one system can be involved. It is hyperinflammatory. That is, it is because of the inflammatory response of the child who gets COVID infection, and it follows exposure to SARS-CoV infection. That means it happens after the child has been exposed to a virus. So this is something like post-streptococcal glomerulonephritis or post-infection things that we get to see. And there were a lot of cases, and which you can say it's a temporal association as well, because we had a wave, we had a COVID infection, we had a peak, and following that peak, there was an upsurge in the cases of MIS, and it affects children. So there have been reported cases of this hyperinflammatory syndrome in adults as well, but globally it has been observed that it's the children and adolescents who are bearing the brunt, and most of the cases are being seen in children. So it was first reported from UK in April 2020, and it was altogether a new entity and new phenomena for all of us. So nobody knew how to diagnose or what to do in such a cases. But over a period of time, we got to see many such peaks in different countries, and India is no exception. So we had this peak, this outbreak of MISC cases. We had a lot of cases who had some feature or other which made us to think that these are cases of MISC. So how common is that? So if you compare out of all COVID cases in children, so it's less than 10%, because as you all are aware that till now we have fortunately have not seen COVID-19, florid COVID-19 infections like with ARDS and like the picture that we have in adults, the same picture in children. So if we compare it from adults, it's very rare, it's very uncommon in children. And in children, if you consider total number of cases of COVID infection in children, then less than 1% of these children, they have MISC as the presentation. And fortunately, again, less than 10% of children who had to be hospitalized with COVID-19 infection because of some reason or the other. So less than 10% of the children, they had this hyperinflammatory syndrome. So coming to the pathogenesis, why children, they behave differently from that of an adults. Adults, they have florid, they can have either asymptomatic infection, they can have mild, and they can have severe COVID infections. But what makes children so different? How do they behave so differently to the same COVID infection? So the exact pathogenesis is not known. So exactly it's not known why why children, they have MIS and not the active COVID infection like in adults. But it is for sure seen in children who have history of exposure to an adult who has had COVID infection, or who was in close contact with a person who is suspected to be a case of COVID. So this thing was common, that almost all of them had some sort of other of the exposure to COVID cases. Then the possible postulated mechanism of this hyperinflammatory syndrome have been, it's because of immune dysregulation, because it takes time. It does not happen with COVID, but it happens after the child has been exposed to this infection, this COVID virus. So it is because of immune dysregulation, and it's not because of direct viral invasion, but it's because of body's response. So the children, they respond differently to the same infection. So it's because of the immune dysregulation, and it involves both pronged, like it has activation of both T cells and B cells. So it is because of dysregulation of both T cells, humoral immunity, as well as cell-mediated immunity, which leads to children having this syndrome of MIS. So coming to a pictorial description of the same. So as you can see, most of the children, once they acquire infection, once they are exposed to this SARS COVID infection, so most of them, they are either asymptomatic or they are mildly symptomatic. So most of the cases, they recover and we do not get to know whether the child was infected or not. And the virus, it lodges itself like in adult best in the nasopharyngeal space of the children. But what happens in children, rather than going to the lower respiratory tract, because receptors are not there for the virus in the children, so rather than lodging and causing all the features of lower respiratory tract infection that we see in adults, such children, not all the children who have COVID, but some children, they have activation, they have hyperactivation of the immune system. So this might act as an, you can think like it might act as a super antigen in certain individual, in certain maybe genetically predisposed children who have activation of both the helper, both the cell lines, both the cell-mediated immunity as well as the humoral immunity. So there is production of plasma cells which produce antibodies. Then there is production of this interleukins, tumor necrosis. So all the inflammatory markers, they are increased, which cause the characteristic cytokine storms. So what happens because of the immune hyper stimulation? So these all chemical mediators, the interleukins, the chemokines, the interferons, the tumor necrosis factor beta. So these are elevated many folds high in the blood, in the circulatory system, and they can cause clinical features which are not confined to any particular system, but it can involve almost any system of the body. So that is the reason there was so much of confusion and ambiguity related to it, because the children, they could present with simple, as you can see, a simple mucosal inflammation. So they could have just finding confined to the mucosa of the child, or they could have meningeal irritation. So there were many children who presented with aseptic meningitis. All of a sudden we had, and I'm sure if you have pediatricians among us, though they will agree with me. So we all of a sudden we started seeing many atypical cases, like they were not fitting into any particular criteria, but they had involvement of many system, more than one system. So they presented with multi-organ dysfunction or involvement of many organs. So some they presented with cardiac involvement, some they had respiratory tract involvement. So we had almost no system spared, and the children, they had, because of this cytokine storm, because of this immune dysregulation, they had all the inflammatory signs and symptoms in the children. And the direct invasion of virus is not a very common mode. So it's because of the body's reaction to this viral invasion rather than the direct toxicity by the virus, which causes this particular syndrome of MIS. So the same thing explained here. So we have two scenarios in certain individuals, in certain children, where the viral load was less because of some reasons. They did not have a very high viral load. So such children, though they also mounted an inflammatory response that was along, and that showed a peak along with the viral load. So as the viral load increased, they had inflammatory response. But as subsequently the child's immune system got cleared of this virus, subsequently over a period of time, these interleukins, these chemokines, they subsided, as you can see here. So in children who had low viral load, they had a rapid viral clearance, they had early interferon response, and they had less of inflammation. So these are the children who presented with a mild disease. So the recovery was characterized by formation of protective antibodies. So what happened? They had a clear a clearing of the virus in a short period of time, and they manifested very mild disease vis-a-vis children who had a severe disease. So what happened in those children? These children, they had high viral load. So subsequently, when the viral load was high, so such children, they mounted more florid and more intense and more prolonged interferon response. So they also mounted the response, the same chemokines stimulation, but it was more intense, more severe, and it was persistent for a more longer period of time. So these are the children who had this typical presentation of severe COVID or post-COVID or a severe disease, which could be a case of MISC. So they were the children who had high viral load. They behaved differently, and these are the children who contributed the complicated cases of SARS. So coming to the clinical features, as I said, because it is an hyperinflammatory, so inflammation does not spare any of the system. So the children they can present with any feature. So they can have their condition, their symptoms might mimic a simple URTI, a simple viral infection with fever, myalgia. They can have conjunctivitis. They can have lymphadenopathy. They can have mucocutaneous manifestation, or they could present with a systemic inflammatory response, where they could present with respiratory tract involvement. They could present with cardiac failure. They could present with hepatic failure and gastrointestinal involvement. So the characteristic was there was more than one system involved, and they had involvement of any and every system of the body. So that is why there was a confusion, because they were not fitting into a picture of any particular condition. So they could have like thrombocytopenia. Many children, they presented with thrombocytopenia. So it looked like enteric fever, a typical enteric, and they had thrombocytopenia. They could have hyponatremia. So they could have biochemical abnormalities as well. And so this added to the confusion. And a lot of children, they presented like Kawasaki, because it was observed about 6-7 months back that all of a sudden there was an upsurge, a lot of cases who presented with Kawasaki-like, but they were not fitting into the criteria of typical Kawasaki. So they were fulfilling some of the criteria. So it was subsequently found out that some of the children, they were actually having MIS and not Kawasaki disease. So they could have the clinical manifestation, like children may have the strawberry tongue, as you can see here. They can have cracked lips. They can have non-purulent conjunctivitis, which you get to see in Kawasaki disease as well. So they could have mucocutaneous manifestation along with involvement of the systems. So if you go to the clinical spectrum of MIS, so the spectrum, it varied from mild to severe. So there are 3 classes. So all of these classes, these contributed to about roughly 1/3 of the cases. Though if you go from the class 1, so this was seen in 1/3 of the cases. So such children, they presented with hyperinflammation. They showed signs and symptoms suggestive of organ, and more than 6 organs were involved in about 50% of the cases. They mounted a intense cytokine storm. So, and most commonly they presented with gastrointestinal or cardiac. So that was the observation in our setup as well. Like we saw many cases with MISC, and most of them, they presented with either cardiac dysfunction or they presented with gastrointestinal involvement. And about close to 100% of them, they had serology positive. So this is the class 1. Then you have class 2 type. Now this is class 2, in which the children may present with respiratory tract involvement as well. They may present with ARDS. They may present with pneumonitis. So these are the cases which cause most confusion with MIS, with COVID-19, because even COVID-19 children, they may have manifestation, but this is something which happens after 2 to 4 weeks after the child has acquired COVID infection, in which, in this case also, about 80-85% of children, they had RT-PCR positive, like in any COVID case. And this is the group which saw the maximum number of mortality. So this was the group which has the most severe intensity, and the probability of dying was maximum in this group, as compared to the another class C, where the children, they had mucocutaneous manifestation and they presented with incomplete or atypical type of Kawasaki disease. Again, they had serology positive, and RT-PCR could be positive in 1/3 of the cases. And luckily, again, the mortality. So if you see the spectrum of MIS, so they could present with multi-system organ involvement, to just infection and symptoms confined to the respiratory tract, till they can have just mucocutaneous manifestation along with cardiac involvement, where they mimic where they mimic Kawasaki disease. So the spectrum can vary from one end to the other. So they may present like in any way, and this type 2 caused most of the confusion and the most sinister of all. So this caused the confusion, the maximum confusion. So how do you differentiate whether RT-PCR is positive, this child has a respiratory tract, this child has presented with ARDS? So is this COVID? Is this MIS? So how to differentiate? So there are certain pointers, and this we have gathered after we saw many cases of COVID, and this we have taken from this Government of India. He came up with guidelines, like they saw many cases of COVID-19, and they saw there was something like there are certain pointers which could assist you in diagnosing and deciding whether this is COVID-19, because as I said, fortunately, we have not seen many cases of COVID infection, severe type, in children. Vis-a-vis, this is a case of MIS. So GI symptoms, as I said, the gastric symptoms, the gastrointestinal symptoms, and the cardiac symptoms, these were more seen in MIS cases. So children who had this COVID infection and who had MIS, so they presented more with either GI symptoms or hepatic dysfunction, cardiac dysfunction, which was most commonly in the form of myocarditis and left ventricular dysfunction, and also coronary artery aneurysm, which you get to see in, so you can see the confusion. Okay, so children with MIS, they have cardiac involvement, they have gastrointestinal involvement, and they have mucocutaneous manifestation as well. So they are causing more confusion with Kawasaki disease. Or if they have respiratory tract involvement, so maybe this is a case of COVID-19. So there the confusion lies. Whereas in children who have COVID infection, they have the most common presentation remains in them is the respiratory tract involvement. See, so if you are confused, so it's not hard and fast rule, but it was observed that more children who are present with MIS, they presented with gastric involvement and cardiovascular involvement, and they have mucocutaneous manifestation as compared to children who had COVID, who had more of respiratory tract features. Then if you go to the biochemical parameters, this the children with MIS, they have low total leukocyte count with a relatively neutrophilia. So they have more of a neutrophil proportion as compared to the lymphocytes. And the CRP levels, if you compare it with the COVID cases, so they had the CRP levels in the higher range as compared to children who had COVID. Got it? So how to differentiate between, now this was one confusion, MIS versus COVID. Is it MIS, especially the type 2 part, which had respiratory symptoms? So if you compare why MIS with Kawasaki, because a lot of children, they presented with Kawasaki-like picture as well. So if you go, again, there are certain pointers, like Kawasaki disease is seen in 4 to 5 years of age, whereas for MIS, we had a broad range. So we saw children ranging from few months of age, 5 to 6 months of age, till the adolescent. So there was a broad age range, which is not seen in Kawasaki. They had more of prominent GI and neurological symptoms. Many of them, they presented with aseptic meningitis-like picture, like encephalopathy-like picture, which you don't get to see in Kawasaki disease. And they may have like mucocutaneous manifestation. Some of them they had, and some of them they did not have. So if they had, they definitely they cause a confusion. Otherwise, MIS children, they may or may not have mucocutaneous manifestation, and they presented more in shock. Like we had children who had presented in cardiogenic shock, so which is normally not so commonly seen in Kawasaki disease. And they had features of other features of cardiac dysfunction, like arrhythmias, like conduction blocks, like left ventricular dysfunction. Okay. Then children with MIS, they had lower thrombocytopenia was seen in many children, which you don't get to. You have thrombocytosis more commonly in Kawasaki disease. And I said they had total leukocyte count was reduced with a increase in the neutrophils and the CRP levels. So if you go by biochemical parameters, they have thrombocytopenia, they have neutrophilia with a reduction in absolute lymphocyte count, and they had higher CRP levels as compared to non-MIS cases or Kawasaki disease. But these children, they presented with coronary artery abnormalities. And as you all know that Kawasaki, why are we wary of Kawasaki? Because many children, they may have residual coronary artery abnormalities if the child has Kawasaki disease. And for MIS, they are mimicking Kawasaki, but not filling into the criteria. So we don't know for sure that coronary artery abnormalities, which is due to MIS, whether this is going to cause the same problem in the future. So it's too early to say. We are still too young in this field to comment upon that, but maybe future studies, and if we follow such children with MIS in the near future, then we can say with more accuracy whether children with MISC, they are going to have like residual coronary artery disease in the future or not. So MIS, how to investigate? So once we are confused and we have a child who presents with MIS, so how to investigate? So the investigation in a child who is suspected case of MIS is a true tier approach. So if a child, when do you suspect? If a child has fever for more than 38 degrees, if he has clinical features. Now these clinical features are so vague that he has involvement of any one or two systems, any symptoms, fever. So you think about MIS. And similarly, this holds true for the third criteria, because epidemiological link. Now, when we saw the third wave, so almost this was something which was positive, which was there was no family spared. So this positive link was seen everywhere. So this was something which was universal. Everybody had exposure, and this holds true in the current scenario as well. So this 0.3 is applicable in almost all the cases. So in any child who presents with features and he presents with clinical features suggestive of MIS, so you have to look for two things: whether the child is in multi-organ dysfunction or he is in shock in any life-threatening condition. If the answer is yes, then you should subject such children to both tiers of investigation simultaneously. In other situation, if you have, again, you suspect a case of MIS, but the child does not have this life-threatening any acute insult which can lead to mortality, so you should subsequently investigate the child in a sequential manner. You should subject him to the tier 1 investigations, and if these are positive, then followed by tier 2 investigations. Okay, so out of clinical features, when do you suspect? If the child has mucocutaneous manifestation, like if there is a rash or bilateral non-purulent conjunctivitis or inflammation of the limbs, especially the hands, if there is hypertension and shock, if there is any evidence of myocardial dysfunction, this could be clinical, like the child has myocarditis, the child has pericarditis, or there are findings on echo, especially left ventricular dysfunction, along with abnormal biochemical parameters like troponin P and BNP. So if these are elevated, if there is any evidence of myocardial dysfunction, if there is an evidence of coagulopathy like PT and APTT and D dimers are prolonged, and the child has acute gastrointestinal involvement, like he presented with diarrhea, vomiting, and abdominal pain. So in the presence of 2 out of these 5, if a child qualifies any 2 of the criteria, then you should think that this could be a child with MIS and should subject the child to subsequent investigation. So what comes under tier 1 evaluation? A complete blood count where you can have a TLC reduced, total leukocyte reduced with the relative neutrophilia. Then a complete metabolic profile. You should always check with liver function test, kidney function test, a blood gas analysis, blood sugar levels, and serum albumin levels. Then biochemical parameters, which again will help you in arriving at a diagnosis: the C-reactive proteins, inflammatory markers, and ESR, and serology, the COVID serology, RT-PCR or antibodies. As I said, such children, they may not have RT-PCR positive, but they may have antibody positive. So in ideal situation, you should get both the things done, both the antibody levels as well as RT-PCR for SARS coronavirus, so that you get to know that this child is a case of MIS. So what constitutes a positive screen? So if the CRP levels are more than 5 and or ESR is more than 40. So both should be present to call it a positive screening. Absolute lymphocyte count should be less than 1,000. The lymphocyte levels go down, whereas the neutrophil levels go up. There is thrombocytopenia. The platelet counts are less than 1.5 lakhs. There can be hyponatremia and there can be hypoalbuminemia. So this constitutes a positive tier 1 evaluation. And what is tier 2 evaluation? So again, going to the same thing, if the child is in life-threatening situation, if he's in shock, then you should get these both levels, tier 1, tier 2 simultaneously. Otherwise, you should get tier 1 evaluation done first. And if the screen comes out to be positive, then you should subsequently go to the tier 2. So what is tier 2 evaluation? Now here you are going for more specific tests like cardiac, because many children present with cardiac dysfunction. So you have to get one ECG done, you have to get one echocardiogram done, along with biochemical parameters which suggest cardiac dysfunction like proBNPs and troponin Ts. Then inflammatory markers, definitely, because hyperinflammation is the basis behind MIS. So what are these inflammatory markers? It's procalcitonin, prothrombin time, APTT, D dimers, LDH, and if the expertise is available, facility is available, then even a cytokine panel. So this is, you are looking for biochemical parameters, markers for inflammation, followed by a blood smear. So what constitutes a positive tier 2 screen? So in cardiac, you can have left ventricular dysfunction, which was most commonly observed, and with ejection fraction less than 35. So any ejection fraction less than 35% has to be taken seriously, and coronary, because coronary artery abnormalities are very commonly seen in MIS cases. So you have to look for coronary artery diameter and more than 2.5 Z score. Again, that has to be treated. And valvular dysfunction. So you have to look for where there is any evidence of valvulitis or myocarditis, supported by biochemical parameters, which again says BNP is elevated more than 400 or elevation of troponin T. As far as inflammatory markers are considered, so procalcitonin levels, PT, APTT, D dimer, again, it was being done in almost all the children, and it's more levels more than 5 types, and the laboratory upper limit of laboratory value has to be taken as positive, high fibrinogen levels, and a cytokine panels, LDH, if the expertise is available. And in a blood picture, you can see schistocytes and burst cells. So these all constitutes a positive tier 2 screening in a child. So what is the different criteria? Because the world was fighting with this MIS, and this was new to almost every country in the world. So all of the international bodies, they came up with their own guidelines. Like we have international bodies, even American Heart Academy, and we have this Royal College of UK. They had presented with their own guidelines. So we are following WHO criteria for diagnosing a child with MIS. So what are the parameters? Any child between 0 to 19 years who has a fever of at least 38 degrees Celsius for more than or equal to 3 days, where there is involvement of multi-systems, more than one system is involved, and you have evidence of inflammation, either mucocutaneous or you have laboratory parameters to prove that. And the most important is once you have excluded other diseases. So because once you are working in a setup, so you are more familiar with the conditions, with the diseases that you are seeing in your setup. So this is very important and very challenging aspect. You have to exclude the common conditions. Like last month, if you know, I don't know how common that was and how famous that was made. We saw an outbreak of cholera-like illness. Like we had closely like 100 and 200 cases of children who presented with acute gastroenteritis. So we all got confused कि MIS है या simple gastroenteritis. So subsequently it was proved कि gastroenteritis है. So you have to exclude. So it's not क्योंकि अगर आप if you go by the criteria, so every child जो आप बच्चे जो भी बच्चा आप देखते होंगे, so they will qualify the criteria. हर किसी को fever होता है, 1 या 2 सिस्टम हर जगह पर मिल जाते हैं, meningitis भी आ रहा है, gastroenteritis भी आ रहे हैं, enteric fever भी आ रहे हैं. So you have to really make a judgment कि ये MIS के cases हैं या ये हमारे दूसरे मलेरिया आना कॉमन शुरू हो गया, डेंगू आना शुरू हो गया है. So depending upon the situation and the scenario where you are working, you are well versed with what is common in your setup. तो आपको हर केस को नहीं इन्वेस्टिगेट करना है, बट जुडिशियसली यू हैव टू सी कि आपके यहाँ कौन सी चीज ज्यादा कॉमन है और क्या क्या और कंडीशंस हो सकती हैं. तो इट्स नॉट MIS, इट्स नॉट अ ब्लैंकेट टर्म कि आपके 10 एडमिशन में आपने सबको टेस्ट करा लिया कि 2 पॉजिटिव आएंगे. सो दिस इज नॉट अ वेरी गुड वे ऑफ डीलिंग विद सच केसेस, क्योंकि एज आई सेड कि फॉर्चुनेटली मोर्टेलिटी बहुत लो है, बट आपको हाँ डायग्नोज करना है. सो यू हैव टू ऑलवेज थिंक अंडरलाइंग इन्फेक्शन भी हमारे यहाँ सबसे कॉमन है और हमको उसके बारे में सोचना है. ठीक है. एपिडेमियोलॉजिकल लिंक अगेन ये दिस इज समथिंग व्हिच इज ट्रू फॉर ऑल द केसेस. हर फैमिली में पूछो तो या तो किसी को पड़ोस में किसी को कोविड हुआ है या फैमिली में लॉस हुआ है, दे हैव लॉस्ट देयर नियर एंड डियर वंस इन कोविड. So this is very common, जो almost हर केस में हो रहा था. So I agree this causes a lot of confusion, but यहीं पे your clinical sense comes into play. तो आपको बहुत judiciously you have to decide. So it all boils down to one thing. There is no single diagnostic laboratory test for diagnosis. कोई ऐसा टेस्ट नहीं बना है मलेरिया की तरह कि हमने टेस्ट कराया तो पॉजिटिव आ गया and then you can say with precision this is MIS, this is malaria, this is dengue. So there is nothing so sensitive for MIS. तो आपको clinically देखना है, but in cases where you have high index of suspicion, और especially जो हम third wave जिसको हमें लग रहा है कि अब आएगा तब आएगा, especially so that is why we are all gathering here and we are talking about this. So we have to keep this thing in mind. Infections तो आते रहेंगे, but infections में हमको MIS के cases कौन से हो सकते हैं, we have to pick those cases up and we have to diagnose and provide treatment to them in a timely manner. Okay, especially third wave आएगी, हर जगह prediction है बच्चों में, some are saying कि आएगी, some कह रहे हैं it's already over. So we don't know what the future holds for us. So, but we should be well prepared. हमको सारी scenarios के लिए we should be prepared. We should know there is something like MIS जो बच्चों में हो सकती है, हो सकता है और आए, हो सकता है ना आए. So we don't know as of now. So हमें इसको कैसे मैनेज करना है, हमें कैसे डायग्नोज करना है और हमें कैसे इन बच्चों को मैनेज करना है. दिस इज समथिंग विच शुड बी लाइक हैमर्ड इनटू अस, और हमें बिल्कुल ही प्रिपेयर्ड रहना है, सो दैट इफ गॉड फॉरबिड वी सी सच चिल्ड्रन, दोबारा से ऐसा कोई आउटब्रेक आए, सो वी आर वेल इक्विप्ड एंड वेल prepared to manage such children. So how do we manage? If you know the pathogenesis, so managing such children becomes easy. इसका pathogenesis सबसे पहले क्या है? Immune dysregulation, hyperinflammation है. So we have to take care of this hyperinflammation. तो इसको how do we take care of any hyperinflammatory state? वहाँ पर आपको immunomodulators, immune dysregulation है, so you have to give drugs which can modulate this immune dysregulator. तो हम कैसे करते हैं? जो common सबसे common drug होती है immuno, जो हम corticosteroids use करते हैं, IV immunoglobulins यूज कर सकते हैं, और बायोलॉजिकल एजेंट्स, जो कि प्रॉब्लम इंटरल्यूकिन है तो इंटरल्यूकिन रिसेप्टर एंटागोनिस्ट बहुत ही जो है रेयरली मिलता नहीं है, इट्स नॉट सो कॉमनली अवेलेबल, बट वी शुड नो कि हाँ अगर हमारा फर्स्ट लाइन नहीं वर्क कर रहा है, सो देयर आर वेज जहाँ पर हम बच्चे को भेज सकते हैं. Then this is one aspect, you have taken care of the immune dysregulation. Then another way should be and could be management of procoagulant state. यहाँ पर जो है कार्डियक डिस्फंक्शन हो रहा है, इम्यून जो इन्फ्लेमेटरी मार्कर इतने ज्यादा बढ़ गए हैं बॉडी में, सो इट ऑल लीड्स टू अ प्रो इन्फ्लेमेटरी स्टेट. ठीक है, तो थ्रोम्बोसिस, स्ट्रोक के चांसेस बढ़ सकते हैं, लेफ्ट वेंट्रिकुलर डिस्फंक्शन है, सो यू हैव टू टेक केयर ऑफ दैट. और वो हमें उसके इसीलिए हमको स्पेशली इको में कोरोनरी आर्टरी एब्नॉर्मलिटी देखनी होती है, क्योंकि अगर वो एब्नॉर्मलिटी है, डायलेटेशन है, इजेक्शन फ्रैक्शन कम है, सो ऑल द मोर रीजन दैट दिस चाइल्ड माइट हैव अ सब्सिक्वेंट प्रो जो है थ्रोम्बोएम्बोलिक फिनोमेना इसमें हो सकता है. सो इन सच सिचुएशंस यू हैव टू गिव एंटीप्लेटलेट ड्रग्स एंड यू हैव टू गिव एस्पिरिन एंड एंटीकोगुलेशन डिपेंडिंग अपॉन द केस एंड सपोर्टिव केयर. सपोर्टिव केयर इज समथिंग जो आपको हर बच्चे में देना है, बस आपको ये देखना है कि आपको इसका कितना जो है प्रोकोगुलेंट स्टेट के लिए क्या क्या स्टार्ट करना है और क्या क्या आपको इम्यूनोमॉड्यूलेटर्स हैव टू बी स्टार्टेड इन सच चिल्ड्रन. सो दिस इज अ वेरी गुड चार्ट अगेन गिवन बाय मिनिस्ट्री ऑफ हेल्थ. सो if you go by this chart, तो if you see कि हमने सबसे पहले ये देखा कि जहाँ पर हमने सस्पेक्ट किया कि हमारे बच्चा this is perhaps a case of MIS, तो हमें सबसे पहले जज करना है कि क्या कार्डियक डिस्फंक्शन या शॉक है, क्योंकि शॉक बहुत कॉमन फीचर था, बच्चे शॉक के साथ प्रेजेंट हो रहे थे, कार्डियोजेनिक शॉक के साथ प्रेजेंट कर रहे थे. तो whether the child has cardiac dysfunction, shock, whether the child has coronary artery abnormality, whether the child is a case of multi-organ dysfunction, systemic failure के, hepatic failure के, neurological shutdown, इस तरह के केस मिल रहे हैं, या एनी लाइफ थ्रेटनिंग कंडीशन है. इफ द आंसर इज यस कि MIS आपको लग रहा है और ये सारा लाइफ थ्रेटनिंग, एक्यूट लाइफ थ्रेटनिंग कंडीशन है, तो यू डोंट हैव टू थिंक ऑफ एनीथिंग एल्स. फॉरन यू हैव टू स्टार्ट द चाइल्ड ऑन इम्यूनोमॉड्यूलेटर थेरेपी. ठीक है, तो उसमें हम क्या कर सकते हैं? IVIG, इफ इट्स अवेलेबल देन इट्स बेस्ट कि आप IVIG 2 ग्राम पर kg थोड़ा स्लो देना होता है, आपको 12 to 16 आवर्स में देना होता है. और अगर बच्चा कार्डियोजेनिक शॉक लेकर आया होता है, मायोकार्डाइटिस होता है, तो और स्लो हो जाना होता है ओवर 48 आवर्स पीरियड. तो स्लोली आपको IVIG देना होता है, एंड अलोंग विद IVIG यू आर सपोज्ड टू गिव मिथाइलप्रेट. ठीक है, मिथाइलप्रेट 1 to 2 मिलीग्राम पर kg पर डे. ओके, बट इफ द सिनेरियो इज, मतलब आपने बच्चे को PICU में शिफ्ट किया और आपने ये दोनों चीजें इम्यूनोमॉड्यूलेटर थेरेपी फॉरन से स्टार्ट कर दी. इफ द सिचुएशन इज कि बच्चे में MIS आप सस्पेक्ट कर रहे हैं बट ही इज स्टेबल, इसमें कोई भी ये लाइफ थ्रेटनिंग इवेंट नहीं है, तो फिर यू हैव टू एक्सक्लूड बाकी इन्फेक्शन. तो इसमें है कि ऐसा है कि ट्रीटमेंट आप थोड़ा सा डिले डज नॉट मीन कि 2-3 दिन के लिए, बट एटलीस्ट यू कैन जो है सेंड सम प्रीलिमिनरी इन्वेस्टिगेशंस, और आप देख सकते हैं कि कहीं ये मलेरिया, सेरिब्रल मलेरिया तो नहीं है, या कोई एक्यूट इन्फेक्शन जो आपके यहाँ ज्यादा कॉमन हो रहा है वो तो नहीं है. एंड दिस चाइल्ड रिक्वायर्स मिथाइलप्रेट. अगर ये नहीं है, आप इन्फेक्शंस जो है ट्रॉपिकल इन्फेक्शंस एक्सक्लूड करिए, एंड यू कैन स्टार्ट द चाइल्ड ऑन मिथाइलप्रेट, द सेम डोज 1 to 2 मिलीग्राम पर kg पर डे, और IVIG. ठीक है, अब दोनों चीजें हैं, लेकिन अगर IVIG अगर लाइफ थ्रेटनिंग है तो IVIG हैज टू बी गिवन. If the child shows improvement, that's very good. If the child does not show signs of improvement, तो you can repeat IVIG, या मिथाइलप्रेट की डोज जो थोड़ी सी इंक्रीज करके दे सकते हैं. जो भी हम 1 to 2 दे रहे थे, हम उसको 10 तक पहुंचा देते हैं. ठीक है, तो 10 मिलीग्राम पर kg फॉर 3 to 5 डेज. ये स्टेरॉइड जो हम देते हैं वो 3 to 5 डेज के लिए देते हैं, फिर हम हर 5-6 डेज पे 25% डोज कम करते हैं, सो दैट वी कैन टेपर इन द नेक्स्ट फ्यू वीक्स टाइम. ठीक, एंड इफ द चाइल्ड डज नॉट रिस्पॉन्ड, दोनों चीजों को नहीं रिस्पॉन्ड कर रहा है, जो यूजुअली बहुत कम केसेस में जो है देखा गया, आमतौर पे मोस्ट ऑफ द चिल्ड्रन दे डिड रिस्पॉन्ड, तो फिर आपको एनाकिंड्रा या सेकंड लाइन या बिल्कुल ही आपको स्टेट ऑफ द आर्ट ट्रीटमेंट के लिए यू हैव टू लुक फॉर दैट. अदरवाइज मोस्ट ऑफ द चिल्ड्रन दे डिड रिस्पॉन्ड टू योर IVIG एंड मिथाइलप्रेट. Then what are the indications of procoagulant? As I said, कि जो procoagulant state है, so what are the indications of anticoagulant? I'm sorry, I should say. So there is options we have is enoxaparin and aspirin. So aspirin should be given if the coronary artery abnormality, if the aneurysm, the Z score is more than 2.5. So this is something which your cardiologist can tell you कि उसका Z score क्या है coronary diameter का. If it's more than 2.5, so that means procoagulant state है, and such children need to be put on aspirin at a dose of 3 to 5 milligram per kg per day. बस आपको ये देखना होता है कि बच्चे के प्लेटलेट काउंट्स एटलीस्ट 80 जो है 1000 से ऊपर होने चाहिए, so that you are preventing this thromboembolic phenomena from happening. अब heparin कब देना चाहिए? जब ये आपका Z score more than 10 है, ठीक है? तो अगर more than 2.5 है, you start aspirin, और अगर more than 10 है या there is evidence of thrombosis का evidence ही आपको मिल रहा है, या left ventricular ejection fraction बिल्कुल ही 35% से कम हो गया है, so these are the children where you have to start the children on no molecular weight heparin. Okay, so this is how you start children on these drugs. आपको जो है फिर मॉनिटर करते रहना होता है धीरे धीरे. हम जो स्टेरॉइड है कितने दिन के लिए देते हैं? 3 to 5 days के लिए देते हैं, फिर धीरे धीरे करके उसको 25% कर करके टेपर करते जाते हैं. हम एस्पिरिन जो है वो शुरू में 2 weeks के लिए देते हैं. सिमिलरली फिर हम प्रोलॉन्ग कर जाते हैं, 4 to 6 week तो लगता है एस्पिरिन देने में, और साइमल्टेनियसली हमको जो है वो उसका इको से मॉनिटर करना होता है. पहले हम शुरू में देते हैं, जो हम पहले दिन इको करके देखते हैं, व्हेन वी सस्पेक्ट MIS, फिर हम 48 आवर्स में देखते हैं कि हमारे ट्रीटमेंट को बच्चे ने कैसे रिस्पॉन्ड किया, फिर हम 1 week के बाद देखते हैं, फिर हम 2 weeks के बाद, फिर ग्रेजुअली हम बच्चे को डिपेंडिंग अपॉन हाउ मच इम्प्रूवमेंट और नो इम्प्रूवमेंट द चाइल्ड इज शोइंग, वी डिसाइड अबाउट फर्दर कोर्स ऑफ मैनेजमेंट. ओके, सो ड्यूरेशन ऑफ थेरेपी सबसे इंपॉर्टेंट ये होता है कि कितने दिन देंगे. तो एज आई सेड कि इम्यूनोमॉड्यूलेटर हम जो है स्टेरॉइड्स तो 3 to 5 days देके फिर उसको ग्रेजुअली ओवर वीक्स टेपर कर देते हैं. साइमल्टेनियसली हम दोनों तरह से क्लिनिकल मॉनिटरिंग देखते हैं, हम इकोकार्डियोग्राफिक यानी लेबोरेटरी मॉनिटरिंग देखते हैं, और साथ में हम बायोकेमिकल मॉनिटरिंग भी करते हैं. लाइक हम प्रोबीएनपी देखते हैं, प्रोपोनिन देखते हैं फॉर कार्डियक इंप्रूवमेंट, और साथ में हम जो है डी डायमर्स और सीआरपी जो बहुत ही एलिवेटेड था, सो वी सी व्हाट द ट्रेंड्स आर. अगर बच्चा इंप्रूव हो रहा है तो डी डायमर्स और जो है आपका सीआरपी धीरे धीरे कम आना शुरू हो जाता है, तो उसके बाद यू डिसाइड. तो एस्पिरिन हम 1 month तो एटलीस्ट 4 to 6 days तो मिनिमम होता ही है, एंड द सब्सिक्वेंट डिपेंड्स अपॉन कि कितना उसके एबनॉर्मलिटी रेजिडुअल रह गई. अगर नहीं है सो यू कैन टेक अ डिसीजन, और कोई अंडरलाइंग कोई भी रिस्क नहीं है, सो यू कैन टेक अ डिसीजन कि हम इसको स्टॉप कर सकते हैं. अदरवाइज इट हैज टू बी कंटिन्यूड फॉर लॉन्ग. इफ द कोरोनरी आर्टरी एबनॉर्मलिटी परसिस्ट, अगर रेजिडुअल रह गई है तो आपको और लंबा देना पड़ेगा. सिमिलरली फॉर लो मॉलिक्यूलर वेट हेपेरिन 14 days के लिए यू गिव एंड यू कीप मॉनिटरिंग. ठीक है, थ्रोम्बस अगर बन गया है तो वो कैसे रिजॉल्व कर रहा है, बायोकेमिकल पैरामीटर्स कैसे रिजॉल्व कर रहे हैं, इको में कितना इंप्रूवमेंट हो रहा है, लेफ्ट वेंट्रिकुलर डिसफंक्शन कैसा है, कोरोनरी आर्टरी डायमीटर कैसा है. दीज थिंग्स आर शोइंग इंप्रूवमेंट, सो ग्रेजुअली यू कैन सब्सिक्वेंटली फॉलो अप में आप धीरे धीरे ये सारी चीजें स्टॉप कर सकते हैं. ठीक है, एंड दिस ऑल गोज अलोंग विद द सपोर्टिव ट्रीटमेंट. आपको सपोर्टिव ट्रीटमेंट, बिकॉज बहुत ज्यादा एप्रीहेंशंस थे, बिकॉज स्टिल वी आर वेरी मच स्केयर्ड एंड एप्रीहेंडेड, बिकॉज वी डोंट नो कि MIS का फ्यूचर प्रोस्पेक्ट्स क्या होने वाले हैं, या क्या ये रिकर होगा, लाइक रोमैटिक डिजीज, क्या ये रेसिडुअल कोई कोरोनरी हार्ट डिजीज कर देगा या कार्डियक हार्ट डिजीज, वी डोंट नो, मतलब क्या रेसिडुअल होगा. सो वी रियली हैव टू बी कॉशियस, एंड यू हैव टू गिव ट्रीटमेंट इन टाइमली मैनर, प्रॉपर ट्रीटमेंट. ओवर ट्रीट भी नहीं करना है, अंडर ट्रीट भी नहीं करना है. ओके, सपोर्टिव केयर, दिस रिमेन्स द अंडरलाइंग जो मोस्ट जो स्ट्रॉन्गेस्ट पिलर होता है, दैट होल्ड्स ट्रू फॉर एनी केस. सपोर्टिव केयर तो सबको आपको देनी है. अगर बच्चा शॉक में आया है, कार्डियक डिसफंक्शन लेकर आया है, तो यू हैव टू टेक केयर ऑफ दैट. आपको फ्लूइड्स के साथ, और कभी कभी आपको एनोट्रोपिक ड्रग, डिपेंडिंग अपॉन द केस, आपको एनोट्रोपिक सपोर्ट भी देना पड़ता है टिल द चाइल्ड रिकवर्स फ्रॉम दिस एक्यूट फेज. एंड इफ द चाइल्ड हैज मल्टी ऑर्गन डिसफंक्शन, लाइक आई सेड, सेप्टिक मेनिंजाइटिस, सीजर्स हो गए हैं, like the child has hepatic dysfunction, hepatic failure लेकर आया, तो accordingly आपको supportive treatment जो सिस्टम इन्वॉल्व हुए हैं, they should go hand in hand. और आपको जो है ये भी जरूर इवेलुएट करना है कि बच्चे को कोई अंडरलाइंग ट्रॉपिकल इन्फेक्शन तो नहीं है, इसीलिए हम एम्पेरिक एंटीबायोटिक थेरेपी भी ऐड कर देते हैं, सो दैट वी डू नॉट मिस. और स्पेशली जहां पर आपका बच्चा एकदम शॉक में और लाइफ थ्रेटनिंग एपिसोड लेकर आया है, तो यू स्टार्ट हिम ऑन एंटीबायोटिक सो दैट यू डू नॉट मिस एनी इन्फेक्शन. So what are the outcomes? So fortunately, this is the best part about MIS as of now. अभी तक जो हमें पता है कि outcomes have been favorable, at least acute जो immediate post hyperinflammatory syndrome है, तो outcomes have been good, but we don't know for sure कि आगे जाके इनमें recurrence होगा, या आगे जाके इनमें residual heart disease होगा, या कोई coronary abnormalities होगी. We don't know that for sure, but अभी तक अगर हम कहें कि हमारे बच्चे तो हैं तो मोर्टेलिटी इज वेरी लेस, वो भी उन केसेस में ज्यादा थी क्लास 2 जिनमें वो रेस्पिरेटरी ट्रैक्ट इन्वॉल्वमेंट ARDS के साथ मैनिफेस्ट कर रहे थे, या जिनमें कोई अंडरलाइन मोबिलिटी थी, अंडरलाइन कोई इम्यून डेफिशिएंसी था. So those are the cases whom we lost. Otherwise, most of the children, they did respond to our supportive care and this immunomodulatory therapy. So the take-home message is MIS is not uncommon, I would say, in a current scenario, क्योंकि हमारे यहाँ काफी cases हम सबने देखे अभी. Think of common conditions first. इसका मतलब ये नहीं कि MIS common है तो हम बाकी चीजों के बारे में नहीं सोचेंगे. Malaria भी आएगा, dengue and trach, everything would come. So we have to think of common thing first. Every child is not MIS, but you should keep this thing that this child could be MIS. Then you have to investigate judiciously. There is no point in sending D-dimers और सारी चीजें हर cases में. जहां पर भी आपको high index of suspicion, like family में अभी महीना भर के पहले लोग recover हुए हैं, parents या कोई family member, और अब बच्चे में symptoms आना शुरू हुए हैं, then you should always think that this could be MIS. Do you have to provide good supportive care, because that is the most effective way of managing a child with MIS. Early and judicious use of medication. जहाँ पे भी आपको लगे doubt है, so it's better to give antibiotic and start treatment, and you have to use this investigations very judiciously. And outcome, the best part, as I said, कि outcome जो है favorable है, but that does not mean कि आप बहुत lightly लेंगे, because even one mortality means a lot to us. तो आपको हर case has to be taken and dealt with seriously, and these are certain suggested readings. So thank you so much for your patient hearing. Any questions? Thank you so much.
Thank you, Dr. Aisha, for such a lucid and informative presentation.
Thank you.
And looking at the questions, I think there is one question in the chat. Somebody has asked that if the child does not has a history of COVID-19, then myth is present or absent. So this is the question.
ये जो है, हाँ, this is a very dicey situation, as I said, कि that depends. Like जब हमारे पास cases बहुत ज़्यादा आ रहे थे, तो almost every family, हर किसी के पास present होता ही था. So we were treating. If the child is in acute life-threatening, so you should treat it as MISC. और अगर नहीं है, then you can think and rule out infection first. So that depends upon how the child has presented, and you order antibodies और आप D-dimer सारी चीजें करा के देखते हैं. In the meantime, you can provide supportive care and you can manage. Like shock में अगर आया है, life threatening है, तो you should, और आपको clinical pointers हैं of MIS, so it has to be managed on those lines. Yeah. So that's what I would.
I cannot see no other questions I can see, Dr. Aisha.
Okay.
Thank you.
Thank you.
Thank you so much.
Thank you so much.
So moving ahead to the next presentation, it is on PICU management, general hand hygiene, general care of a child in PICU, and prevention of ventilator-associated pneumonia. I will be giving this presentation. So good afternoon to all of you again. So let's start with it. The learning goals of this presentation are to understand the importance of supportive care, to know the components of general care of a critically ill child, and to understand how to provide a holistic general care. So we all know that whenever we work in a PICU, our main goal is focused on the early identification of any complication or the primary disorder, the assessment of the severity of that disorder, and immediate and early resuscitation of a critically ill patient. So most of the times, this precipitating disorder is the focus of our attention and intervention. However, when we are working in an ICU, we should try to provide a holistic approach of care where our focus should also be there equally on the supportive care. So what do we all include in a supportive care? Basically, it is monitoring of the child, prevention of the nosocomial infections in the children, and ongoing assessment and supportive care. So the importance of monitoring has already been emphasized on all of you in the previous lectures, where we know that we need to measure the physiological indices intermittently in order to assess the response to our treatment, in order to raise any alarms in conditions of acute deterioration. And most importantly, it helps us to maintain a trend in the course of the child's hospital stay. So we should always have bedside vital monitoring charts, which is a very important thing to be had in if we are running any ICU. Second is prevention of nosocomial infection by simple techniques of hand hygiene and the universal precautions. Third is your supportive care. fast, hugs bed. It's a simple mnemonic. You can make a checklist of this mnemonic in your ICU. This checklist, it helps you to keep the track of the key aspects of general care. So let's know what is this mnemonic. So F stands for feeding, A for analgesia, S for sedation, T for thromboembolic prophylaxis, H for head of the bed elevation, U for stress ulcer prevention, G for glucose control, S for spontaneous breathing trial, B for bowel regimens, I for indwelling catheter removal, D for de-escalation of antibiotics. So talking about each of the components one by one, starting with the nutritional support. It is very important for a child in ICU to be properly supported nutritionally, because sepsis, it is a catabolic response state in our body leading to the breakdown of our endogenous proteins. So we cannot stop this process by any means. So what does this feeding does? It helps to attenuate the loss which is happening because of this metabolic stress response. Additionally, it also helps to improve the GI function and integrity. It improves any kind of wound in its healing. It reduces the complications and length of stay. It reduces morbidity and mortality. So now the question arises, how much calorie do we need to provide to a sick child? Normally, in our normal healthy children in our wards, we base our dietary, our calories on the basis of the dietary recommended allowances. But in sick children, we base it on the basal metabolic rates or the resting energy expenditure. Because if we give it according to the RDA, we may have signs of overfeeding, complications due to overfeeding. So what should be our caloric goal? It is about 27 to 58 kilocalorie per kg per day. And the protein goal is about 1.5 gram per kg per day. Now we need to remember that this is not fixed. In certain situations, in the conditions of fever, burns, sepsis, trauma, or any other, once a child becomes active, we need to increase our calorie. So there are certain multiplication factors which you add to this basic caloric goal. Now, when we're talking about feeding, we need to know the types of feeding. There are main two types, enteral feeding and the parenteral feeding. We all know that the enteral feeding is a physiological mode of feeding. It has a trophic effect on the gut mucosa. It prevents bacterial translocation. As a result, it helps to prevent sepsis. It's simple, cheap, it's very easy to administer, and it has very few complications. And talking about the complications, there are very few, like risk of aspiration, feed intolerance, or the tube displacement. However, parenteral feeding, it is only indicated whenever the enteral feedings are contraindicated. So those conditions are GI bleed, gut ischemia, intestinal perforation, and obstruction. So apart from these conditions, we always go ahead with the enteral feeding. So looking at this comparison, we can come to the conclusion that the enteral feeding is superior to the parenteral nutrition. So whenever a child comes to your ICU, you just have to look at two things: whether there are any contraindications to enteral feedings or not, and whether the bowel sounds are heard. So if both these things are positive, you start the enteral feeds within 24 to 48 hours of admission. While starting the feed, ensure that the head end is elevated. You need to assess for the risk factors for aspiration, like severe respiratory distress in the child or recurrent vomiting in the child, history of previous aspiration, any delayed gastric emptying. So if any of these risk factors are present, then we go ahead with the post-pyloric feeding, that is a nasojejunal or the nasoduodenal feeding. Here what happens, we have to introduce a tube through the esophagus into the duodenum or the jejunum. So this is not a blinded procedure. You need to do it with the help of fluoroscopy. Whereas if none of these risk factors are present, we start the nasogastric feeding, which is a common type of feeding which we do in all our practices. It is a bolus feeding. So because we don't have these fluoroscopic advances in our centers, so mostly we go ahead with the nasogastric feeding. So bolus feeding means we give boluses at frequent time intervals. 2 to 4 hourly, we can divide our feeds into boluses. So our the principles of feeding is that we should start with 25% of the target volume. For example, if you have to give 1000 ml to the child, you do not start with 1000 ml immediately. You give 25% of it. That is 250 ml. So you can divide this 250 ml into numerous feeds. For example, 30 ml feeds every 2 to 3 hourly. Now, after 4 hours, you monitor the child for any feed intolerance signs. So if there are no signs of feed intolerance, you increase the volume by 25% of the start volume.
So for example, in the beginning, you started 30 ml 2 hourly. Then after 4 hours, you can make it 40 ml 2 hourly. Then again, after 4 hours, if there is no problem, you can make it 50 ml 4 hourly. So you keep on increasing till the target is achieved. Now, once we started with the 25 to 70 to 58 kilocalorie per kg per day, the beginning calorie, we do not keep it static. Once the acute phase of illness where the stress response is happening is over, that is about at the 7th to 10th day, we increase the pre-caloric volume by about 50%, so that now there is no underfeeding in the child. Before initiating any feeds, we have to check for the pre-feed gastric residual volume. If it is more than 150 ml, or if it is more than 5 ml per kg, or more than half of the previous volume of the feed. So the easiest way to remember is if it is more than half of the previous feed volume, you should stop the next feed. And you monitor again after the 2 hours of interval. You again monitor for the residual volume. If it is still more than half of the previous feed, you can give prokinetics in the form of metoclopramide or domperidone in the dosages of 0.2 mg per kg per dose 8 hourly. Or an alternative strategy can be that you can give smaller volume feeds. So for example, in the beginning, you were giving 30 ml 2 hourly. So now you can divide your feeds to the smaller volume of 15 ml hourly. Now, once we have decided the volume, now we have to decide what composition of feeds we need to give. Generally, up to 6 months, it is breast milk, or it is express breast milk, or formula milk. In 1 to 10 years of old children, we have milk-based feeds. Other options we have, we can give dal, we can give porridge to the RT tubes. In certain scenarios where despite of our caloric despite of our dietary support, the child is not gaining weight. So here we need to make the diet more caloric dense. So how do we do it? By adding MCT oil, sugar to our milk, or puffed rice to the milk. Apart from this basic nutritional support, we also need to supplement vitamins and minerals according to the RDA. And not to forget, the help of a dietitian in your ICUs to take care of the needs of children can be very beneficial. Now coming to the second component, that is sedation and analgesia. The goal is to attain analgesia, anxiolysis in your patient, and to help maintain patient ventilator synchrony. Now, we should always remember that analgesia and sedation, they are preferred over the neuromuscular blockade because they are quickly reversible, and they also allow for neurological monitoring. So the sedation, it should be given using agents which have minimal effect on your blood pressure. So among our choices, the most preferred is the short-acting benzodiazepines like midazolam. It's given in the dosage of 0.1 mg per kg bolus, followed by an infusion of 1 to 10 microgram per kg per minute. We start from very small dosages like 1 microgram, and then we gradually increase it according to the response in the patient. Fentanyl, it is used for giving analgesia, 1 microgram per kg bolus, followed by 1 to 5 microgram per kg per hour infusion. We should always remember that in pediatric ARDS, we target as sedation using minimal dose. Now, if our sedatives are not completely effective, despite of the higher doses which we are giving, then we need to add neuromuscular blocking agents like vicuronium. It is given in the as a bolus of 0.15 mg per kg, followed by an infusion of 15 to 25 microgram per kg per minute. Now, these neuromuscular blocking agents, they are used in moderate to severe ARDS because they improve the tolerance to mechanical ventilation. They help to optimize the oxygen delivery. We should always remember that we should give minimal possible dose of these agents. Now, we also should provide daily neuromuscular blockade holidays. And during that holiday time of 1 hour to 2 hours, we should monitor the clinical sensorium of the child. And it also helps to prevent development of any critical illness, polyneuropathy in the child. Now, coming to the third component, that is the glucose control. Now, we all know that there is an ongoing stress hormone response during the period of critical illness. Because of this, there is chances of hyperglycemia. So these blood glucose abnormalities are quite common. This hyperglycemia per se, this peak glucose level, and the duration of hyperglycemia, all these are responsible for increased chances of mortality in the child. So we need to monitor the glucose in ICU at least 12 hourly. And once we have found some abnormality, then we should have a frequent monitoring about 2 to 4 hourly. What is our target in ICU? Our target is to keep the BGL less than 150 milligram per deciliter. Simultaneously, we should also intend to prevent any hypoglycemic episodes. Now, if the BGL of your child is persistently more than 180 milligram per deciliter, you need to stop all the fluids which contain glucose. And despite of stopping them also, if still it is more than 180, then it is an indication to start the insulin infusions. There have been two thoughts, school of thoughts, like whether we should have a tighter glucose control that is between 80 to 110 versus a moderate glucose control that is less than 150. So, but it has been found that this tighter glucose control has no added benefits in mortality or in any length of ICU stay. Therefore, our target remains at less than 150. The fourth component is the pressure source. We all know that this is very common in ICUs. The incidence is about 26%. This happens because the child is immobile for long period of time. As a result, there is compression of the vessels leading to ischemia of the skin. The common sites are occipital region, as we can see in the above image. It can be at the earlobe because of the mass, at the nose because of tight fitting mass, chin and the neck, as we can see in the lower diagrams, because of the central veins, central venous lines. In the older children, it can be in the sacral area or in the heel. So the risk factors are prolonged mechanical ventilation, hypotension, malnutrition. In hypotension, initially only there is decreased blood flow. So the chances of further obscuration of the blood supply is high. Malnutrition, there is poor subcutaneous fat. So the vessels have very less support. Sensory loss, dependent edema, central line in the neck, and longer stay of more than 96 hours. All these things are the risk factors for pressure sores. So how can we prevent it? By regularly examining the skin. We should keep repositioning the child. It depends upon the condition of the child. It can be like 2 to 4 hourly frequency. We should maintain adequate nutrition in the child. Try to keep the sheets dry and wrinkle free. This is also a very important point which helps to prevent the pressure sores in our kids. And another, as we can see in the diagram, alternating pressure mattresses, they help to prevent the pressure sores. Now, despite of our efforts, it's still the child develops the pressure sore. We need to be able to identify them. So this is a simple staging where the stage 1, it is this non-blanchable redness. So if this redness develops, which is not blanchable, this is stage 1. So in this, you should start doing protective dressing. Stage 2, as we can see in this diagram, now this ulcer develops surrounded by the red wound. So here we need to start moist dressing in the form of some transparent film, hydrocolloid dressing, and you need to clean the wound with saline or water. Stage 3 is there where there is a full thickness loss and you can see the subcutaneous tissue beneath. Stage 4 is there when everything is lost, including the subcutaneous fat, and the bone skin is visible at the base of the wound. Finally, unstageable when there is an eschar visible. So in these, how do you manage? If there is any necrosis, then you have to go ahead with the debridement, and the same measures for the non-necrotic ulcer, that was moist to adsorbent dressing and cleaning of the wound. Now coming to the fifth component, that is eye care. So eye care is very important in our children because commonly abnormalities of cornea and conjunctiva are seen in about quarter of our patients. So what are the risk factors which lead to this problem? Are the inability to close your eyes, which can be seen in any of the neurological diseases, nocturnal logophthalmos, comatose patients, in infections. And second is iatrogenic because of the use of neuromuscular blockade in mechanically ventilated patients. So all these things lead to exposure keratitis, corneal ulceration, and infection. This is very important to cater because it can lead to vision loss. So how do you provide eye care? With the help of lubricating ointments like artificial tears, you use them to keep your cornea and conjunctiva wet. You use 1 drop every 6 hourly to each eye. Second thing you have to observe is that whether the eyelids are getting closed fully or not. So if they're not getting closed fully, you need to use protective eye taping as shown in the diagram. It is effective as it prevents any future corneal erosions. Antibiotic eye drops are not routinely recommended. They are only recommended when there are signs of infections like discharge. The next component is oral hygiene. Children who are critically ill, they are too much predisposed to oral colonization of drug-resistant organisms. and plaque formation. So these plaques are formed because there is decreased saliva production, and also there is oral drying. Now, these drug-resistant organisms are responsible for ventilator-associated pneumonia. Therefore, we need to understand that this oral maintenance of oral hygiene is extremely important. So how can we maintain it? By regular cleaning of the oral cavity. It is done for both non-intubated and intubated kids. So in intubated, we have to make the special efforts. It is done using the antiseptic solutions. While cleaning, we have to ensure that the dislodged flakes and the secretions, they are not aspirated by the children. So how can you do it? By keeping the head elevated, by ensuring that your ET tube cuffs are inflated. And if you have the facility of closed suction or the inline suction, then you should keep it open while you are doing the procedure. So how do you do this oral hygiene? Simply, you need to follow simple steps. Wash your hands, dry your hands, don disposable gloves, keep the head end of the child elevated to 30 degrees. So depending upon the age, if your child is an infant less than 1 year with no teeth, you just need to wipe the gums and the mucosa with saline. You just have to take a swab, dip it in the sterile water or saline, take it around your gloved finger, and then just wipe the gums and mucosa with it. Our intention is to keep it moist so that no plaques are formed. Secondly, if the child is between 1 to 3 years, has teeth, so apart from this practice of 2 to 4 hourly wiping of your gums with this sterile water or saline, you need to brush the teeth also. So you take small amount of fluoride toothpaste on a soft headed toothbrush so that you do not cause any injury to the gums, and you brush the teeth twice a day. Now in children more than 3 years, apart from these two previous practices, you have one more practice to follow. That is, after 30 minutes of toothbrushing, you have to clean the gums, the teeth and the oral mucosa with 1% chlorhexidine gluconate gel. So this is to be done in children more than 3 years only. Coming to the next component, that is stress ulcer prophylaxis. Critically ill children, they are at risk of developing stress ulcers, and these stress ulcers are the cause of upper GI bleeding. Apart from this, there are other risk factors also present in our children, like thrombocytopenia, coagulopathy, organ failure. If we are giving mechanical ventilation at high pressures, shock, prolonged surgeries, and steroids, as we are talking about COVID scenarios, so steroid itself leads to upper GI bleeding. So is this stress ulcer prophylaxis routinely advised in children? No, it is not routinely advised. On contrary, as we do in adults, because it leads to increased chances of nosocomial infections. So the only indication for giving this treatment, rather, I should say, is GI bleeding. So we need to be cautious in our ICUs and keep observing the children for any nasogastric aspirates. What choices do we have? We have ranitidine, sucralfate, and proton pump inhibitors like pantoprazole. The 8th component is the thromboembolic prophylaxis. Now, venous thromboembolism is being increasingly recognized in children. There are various risk factors for this. First of all, secondary to the illness, sepsis, extremes of ages, complex medical conditions like malignancy, chronic cardiac or renal diseases, prolonged hospitalization, inherited or acquired thrombophilias. So apart from these risk factors, still the most important risk factor is the central venous catheter. We need to know how to identify a thromboembolism. So number one is clinically, as we can see in the above picture, comparing the two legs, the one is more red. It is, we can see it's swollen also, and on touching, we may find it warm. So this is clinical suspicion for venous thromboembolism. The diagnosis is made with the help of ultrasound Doppler. So as we know that it is not routinely advised in children because of the risk of bleeding. But once we have confirmed it using the Doppler, we go ahead with the treatment. Talking about the COVID-19 scenario and MISC, it is advised in severe COVID-19 children and MISC patients, the low molecular weight heparin like enoxaparin, which has already been discussed in the previous talk also. It is given under specific indications like when thrombosis is there, when you have a giant aneurysm with more than 8 mm diameter or more than 10 Z score, or when your D dimer is more than 5 times the upper normal limit. And finally, if your left ventricular ejection fraction is very less, that is less than 30%. But whenever you start, when you have to initiate, you should just rule out the contraindications first. Like severe thrombocytopenia should not be there, The child should not have any end-stage renal disease and no major recent bleeding. How long do we need to give it? At least for 2 weeks after discharge from the hospital, it has to be given. And some longer duration is required in children who had a documented thrombosis, for example, for 3 months at least, the ones who have a very large aneurysm with the Z score more than 10, and in those children in whom the left ventricular dysfunction is not improving at the time of discharge. Now, what dose? Mostly we give 1 mg per kg twice daily subcutaneously, but in smaller children, a bit different dosages are required. Now, once the thrombosis has been identified, the first step you have to do is remove the central venous line which is associated with that limb. Secondly, we have to ensure follow-up ultrasound to screen for the extension of this thrombosis. Now, there are certain measures which can be done previously to prevent the development of thrombosis, like early mobilization of the limb, physiotherapy of the limbs, and compression devices like the stockings. The second agent which has to be given if there is thrombosis is aspirin. And aspirin is also indicated if there is a coronary aneurysm of more than 2.5 Z score. The dose is 3 to 5 mg per kg per day. You have to first of all ensure that there is no thrombocytopenia less than 80,000. There is no active bleeding in the child. The duration is still at least at 4 weeks, till 4 weeks we have to give. And at 4 weeks, we have to ensure that the coronary arteries have normalized. The platelet count has normalized. Now coming to the 9th component, which is care of the lines. So we all know that when a child is admitted to ICU, we have to put various lines like IV lines, central lines, chest tubes, and sometimes peritoneal dialysis catheters. So if a child has IV cannula, we have to have a habit of examining it at least once per shift for any signs of phlebitis. Now this cannula site should always be observed. We have to instruct our nurses that they should observe the cannula site whenever they are giving any bolus injections, whenever any dial flow rates are changed, and whenever the solution containers are being changed. So there is a simple scale which is called visual infusion phlebitis scale. It is a kind of objective scoring system which helps to identify the early signs of phlebitis. And whenever a stage 2 is reached, it is the time when the peripheral IV cannula should be removed from that site and placed somewhere else. So what is stage 2? Just remember the stage 2. It means 2 of the things should be present. Like number 1, the child is complaining of pain when you are pushing any medicines through that cannula. Second, either swelling or erythema. Any 2 present out of this 3, it is an indication that you need to remove the cannula. If it is less than these 3 symptoms, then you can just wait and watch. If the symptoms are even worse, like if the child develops induration, this is stage 3, you need to put thrombophobe ointments, which is a combination of your heparin and benzyl alkonium. It helps in early healing. So finally, if the child develops fever, this is stage 5. Here you need to initiate antibiotics if he's not on them previously. Now coming to the second line, that is the central venous line, you need to monitor it regularly for displacement, for any bleeding, for the patency, which is very important, for signs of infection or for hematoma formation at the site. You should remove it as soon as it is no longer required. That is, if you are able to achieve any peripheral access, you should just remove it. Secondly, if the child develops fever for which no other obvious foci is noted, this central line has to be removed. The next lines are the chest drains. You should assess them periodically for the movement of the fluid column. You should assess for the amount and the nature of the drainage which is coming out, displacement of the tube, the breath sounds, and any development of subcutaneous emphysema. The peritoneal dialysis catheter needs to be monitored for the patency. It should be removed as early the dialysis is stopped. You should take out the PD fluid and the catheter and send it for the culture. Now, finally, a word about chest physiotherapy. It is very important in your ICU because it helps in early recovery of your patients and it decreases the ICU stay. So, what is the mechanism behind this chest physiotherapy? It helps to increase the drainage of the secretions. It improves the ventilation perfusion matching. It decreases your work of breathing, and as a result, it increases your functional residual capacity. Now, this chest physiotherapy, along with this prone positioning in ventilation, is very helpful in the COVID scenarios. Now, this prone ventilation, it helps to increase the FRC. So it helps to increase the oxygenation in early stage of ARDS. And the other things are the same as a chest physiotherapy. It is indicated in severe ARDS. It is not indicated in the mild or the moderate ones. So severe ARDS when your PF ratio is less than 150 or when your oxygenation index is more than 16. Now, awake proning is also a very simple technique which helps to prevent any development of future respiratory complications. So it is advised in children with severe COVID. These are cycles. One cycle consists of 6 steps. In the first, as we can see, we ask the child to lie in the prone position for 30 minutes to 2 hours. Each step is for 30 minutes to 2 hours. The second step is the child is lying on one lateral position. Third, when he is in the semi-fowler position. Fourth, on the other lateral position. Fifth, in the semi-prone position. Sixth, back to the prone position. So this one cycle is repeated again and again. So this is generally helpful in non-intubated children. In adults, it is advised for even moderate cases also, but in children, it is still being investigated for the moderate cases. So the key messages of this first part of the talk is the holistic care is needed for a critically ill child. We should remember this mnemonic, fast hugs bit, keep a checklist of it at the bedside of every child. It will help us to prepare and give a proper holistic care for every child in our ICU. Thirdly, we should give minimal sedation and try for early extubation because it helps to improve outcome. Nutritional support is equally important for early recovery. Physiotherapy should be done regularly to prevent these sores and to help improve the respiratory recovery as well. We should always follow the dictum of first do no harm in our ICUs. This is some suggested reading. Now coming to the second part of the talk, which is asepsis in the pediatric intensive care unit and the prevention of VAP. So the learning goals of this talk is we should understand that what is healthcare associated infections or the nosocomial infections, what are the common ones. We should also know how to maintain the strict asepsis in our wards and minimize the common healthcare associated infections. The importance of hand hygiene, how to do hand hygiene, and the prevention of VAP using the VAP bundle. So healthcare associated infection is any clinical infection, whether it is localized or systemic, that was not present at the time of admission. It is a major cause of morbidity and mortality. It is seen in about 9 to 21% of critically ill children. So among these, the most common one is the bloodstream infection seen in 25 to 30%. The second is your ventilator associated pneumonia seen in 20 to 25%. And the last is your catheter associated UTI in 15%. The risk factors are infancy, prolonged stay in the ICU, severe illness at admission, prolonged use of sedation, broad spectrum antibiotics, and the use of invasive devices like central lines or the catheters. So the question arises that can we reduce it? The answer is yes. Simple standard precautions can help us to reduce these nosocomial infections. Number one is hand hygiene. Second is use of the personal protective equipment. Third is respiratory etiquette, and fourth is safe injection practices. So these are simple placards which you should display near the hand wash areas in your ICUs, because it helps you to every patient, every doctor, every nurse entering into the ICU to do hand hygiene. So generally, if your hands are not visibly soiled, you can go ahead with your hand rub. But if they are visibly soiled, you need to do hand wash. So for hand wash, you can use soap or chlorhexidine and alcohol-based hand washes. For hand rub, we have 0.5% chlorhexidine with 70% ethanol solutions available. Hand rub, we have 7 to 8 steps which have to be followed within 20 to 30 seconds. Whereas hand wash requires about 40 to 60 seconds. Now, when all this hand hygiene has to be done, we have 5 checkpoints. Number one, before patient's contact and before any aseptic procedure. So this helps to prevent transferring of the harmful germs from you to the patient. Third point is after any blood body fluid exposure or after patient contact. So this prevents you and the surroundings from the harmful germs of the patient. Fifth is after contact with the patient's surrounding. So you should always make a habit of doing hand hygiene when you enter into the ICU and doing hand hygiene when you exit from the ICU, even if you have not even touched the patient. Because you may have touched anything else in the ICU, any bed, the bed of the patient, the files of the patients, the infusion pump, anything if you might have touched. Now talking about the personal protective equipments, by now we all are aware about it. The gowns, the gloves, the masks, the hazmat suits. So all these things are done for the safety of our own and also of the others while performing hazardous patient activities, and it helps to interrupt the disease transmission. We all know that donning and proper doffing is very important. So when we are talking about donning, doffing is more important, and we should all be very much well versed with these steps. The next is respiratory etiquette. We should cover our mouth while coughing. So the practice is we should not use our hands, we should use our elbow, that is the upper arm. Secondly, we should, after disposing of any tissues or touching any respiratory secretions, we should do hand hygiene procedure. The next is safe injection practices. Before giving the injections, we have to clean the area with the alcohol swab. Use of the single dose vials and single use needles, they all help us to prevent any nosocomial infections. Then we can display posters in our ICUs and distribute it to the attendants about minimizing the visits and other relevant care. Like before entering, we should remove the slippers and shoes, ornaments, watch. We should wash our hands. We should rub your hands before touching anything. And we should not sit on the beds. We should not touch anything in the ICU unnecessarily. Only the parents should be allowed in the ICUs in adequate PPE. It is our job to explain to the parents and the guardians clearly that these precautions are being taken in the best interest of them and their children. Apart from these basic care, proper disposal of the biomedical waste is very important in normal days also, and in the COVID scenario, it becomes even more important. Then disinfection and sterilization of the ICU and instruments with proper record keeping is important. Time to time culture audit of the admitted patient should be done so that we can have a proper antibiotic stewardship and the rational use of antibiotics in our ICUs. We should send cultures from the wall, ceiling, suction pipes and other areas during regular surveillance. Now coming to prevention of bloodstream infections. So it has been hypothesized and proven also that central lines made of Teflon and polyurethane are associated with decreased chances of bloodstream infections. So we should try to use them, and we should use such lines which have minimum number of ports. We should insert central lines under proper aseptic precautions with scrubbing up to the elbows. We should use other universal precautions. We should drape our patients, do antisepsis of the skin with 2% chlorhexidine and or 10% iodine. We should use sterile gauze or transparent semi-permeable dressing. Any antiseptic ointment should be avoided at the site of insertion. We should change our IV fluid administration sets every 72 to 96 hours. If we are using the pressure transducers for CVP or ABG monitoring, then they should also be changed after 72 to 96 hours. How can we prevent the nosocomial UTI? The catheters, they should not be placed without any indication. For example, if the child has any urinary retention or the child is in anuria, or we have to monitor the urine output in tumor lysis syndrome, unless there is a specific indication, then only catheterize. Otherwise, don't catheterize. When you are catheterizing, do it aseptically. You should use a closed drainage system. Secure the junction between the catheter and the drainage system securely. But if it gets contaminated, then you have to replace this whole system. The catheter should not be irrigated unless it is absolutely necessary. And once the indication is over, remove it as early as possible. Now coming to the last points is the ventilator associated pneumonia. So any pneumonia that develops after 48 hours of mechanical ventilation, which was not initially present, is called VAP. This is the second most common healthcare infection. It is associated with very high chances of mortality, morbidity. It increases the length of ICU stay. It increases the use of antibiotics, leads to antibiotic resistance, and increases the healthcare burden. So it is very important to prevent them. Endotracheal intubation alone itself, it is a very important risk factor. It increases the chances of VAP by 6 to 20 folds. The common etiology are the Acinetobacter, Pseudomonas, Klebsiella, E. coli, and MRSA. How do we prevent it? Simple general measures, as we've already talked about, have to be taken care of, and the specific measures to prevent VAP are called the VAP bundle. It is a series of interventions related to the ventilator care. So it has certain brief points, like it intends to prevent iatrogenic spread of infection. This VAP bundle, it prevents aspiration of gastric contents. It improves the oral hygiene. It decreases the ET tube risk factors. It avoids contamination of respiratory equipment and decrease the duration of mechanical ventilation. So by doing all these things, you decrease the chances of VAP, you decrease the chance of mortality. So what are the items that prevent the iatrogenic spread of infection? Good hand hygiene, universal precaution, and proper isolation techniques. What are the items to prevent aspiration of gastric contents? You keep the head end elevated to 30 to 45 degrees. You monitor the gastric contents, you drain if they are excess, and you avoid the gastric distension. Third is the oral hygiene, which I've already emphasized. It's very important, cleaning with chlorhexidine and brushing the teeth. Then what are the items that decrease the ET tube risk factors? Number one, use of inline suction equipments wherever they are available. They are not generally available at our centers. Second, you should suction the hypopharynx before suctioning the ET. Keep repositioning the child 2 to 4 hourly. Keep the ET tube cuff inflated. Always try to avoid unplanned extubation and unplanned reintubations. The items to avoid contamination of respiratory equipments are also very important to prevent VAP. So for this, number one, you should have a dedicated oropharyngeal suction equipment. That means a different suction catheter for ET suctioning, a different one for the oropharyngeal suctioning. Second, prevent accumulation of respiratory circuit condensate. Whenever there is a condensate you can see visible in the tubings, you should discard it. This will prevent the contamination of the ventilation equipments. Then you should change the circuits when they are visibly soiled or malfunctioning. Only sterile fluid should be used in the humidifiers and nebulization. So this is very important. You should not just take any tap water into the humidifier. Distilled or sterile water should be used only. Then finally, our goal should be to decrease the duration of mechanical ventilation by giving neuromuscular blockade holidays, giving minimal sedation, and doing a daily assessment for the readiness to extubate the child. We should give minimal sedation, adequate levels such that the child is very much awake, but he's comfortable, because over-sedation leads to weaning failure. It leads to depression of the cuff reflex, and it also predisposes to the aspiration of oropharyngeal secretion. So all this leads to VAP. So therefore, practicing all these steps of the VAP bundle helps to prevent the development of VAP and early recovery and discharge of your child. So the take-home message of the second part is what the importance of hand hygiene. It is very important. It is a very small thing. It takes very small amount of time. Please do it in the normal practice of your ICU care. Second, the measures of prevention of common healthcare associated infections and practicing of the VAP bundle. So this is certain suggested readings related to the talk, second part. Thank you for your patient listening. And I'm very thankful to the contributors who have brought this training into life. Thank you. Let's see if there are any questions. Okay, somebody has asked to repeat the mnemonic of the fast hugs bid. So F stands for feeding, A stands for analgesia, S stands for sedation, T is your thromboembolic prophylaxis, F is your feeding, U is your stress ulcer prevention, H is your head of bed elevation, G is glucose control, S is spontaneous breathing trial, B is bowel regimen, I is indwelling catheter removal, and D is your de-escalation of antibiotics. I hope it is clear now. So as I cannot see any questions related to the talk, let's move to the next talk and the last talk of the day, that is handling of the disease. I would like to request Dr. Vineet Singh. He's an assistant professor in GSVM Medical College, Kanpur. Dr. Vineet.
Hello. Good. Hello.
Dr. Vineet,
Hello.
can you hear me?
Yes, ma'am. Yes, ma'am.
Yes,
Should I
please go
start?
ahead with it. Yeah.
Okay. Thank you, ma'am. Okay, good afternoon to all. In this last topic of COVID training, we will be going to discuss the management of the disease. It includes transfer of the dead body from isolation room or intensive care unit to the mortuary or for the cremation or for the burial. Death is almost always associated with a state of great disturbance, confusion, and uncertainty among the relative, and it must be very sensitively handled. As we all know, as per study, COVID-19 third wave is likely to affect the pediatric age group. Up till there are 3.2 crores of lab confirmed cases and around 4.2 lakhs of COVID reported death. The main learning scope of our this topic is to shorten the knowledge gap on how to dispose of the dead body of a suspected or the confirmed case of COVID-19. So how can we do this? We can do this by training in infection prevention and control practices of all the staff identified to handle the dead body in the isolation area or mortuary, ambulance, and those workers in the cremation or the burial ground. One thing we should also understand that main driver of transmission of COVID-19 is through the droplets. There is unlikely to be an increased risk of COVID infection from a dead body to a health worker or family member who follow the standard precaution while handling the dead body. Only lungs of dead COVID patient, if handled during an autopsy, can be infectious to others. So, a skill which has to be enhanced, first is the hand hygiene, second is the proper use of personal protective equipment, and third is the appropriate disinfection. So, for this, we should follow the hand hygiene and personal protective equipment along with the safe handling of the sharp object, disinfect the bag housing the dead body and instrument and devices used on that patient, and disinfect the linen and all the environmental surfaces. So coming to the first part, that is the removal of the body from the isolation room or intensive care unit. First, the health worker attending to the dead body should perform the hand hygiene and ensure the proper use of personal protective equipment. Then all the tubes, that is endotracheal tubes, any ICD drains, catheter should be removed. Any puncture, hole or wound that resulted from the removal of the catheter, drain, tubes or otherwise anything should be disinfected with 70% alcohol or 1% sodium hypochlorite, and then it should be dredged with some impermeable material to avoid any leakage. All the sharp objects such as intravenous catheter should be cautiously handled and it should be disposed of in a sharp container. Plug the oral and nasal orifices of the dead body to prevent any leakage of the body fluid outside. If family wishes to view the body at the time of removal from the isolation room or area, they may be allowed, but with standard precautions. So first, place the dead body in a leak-proof zipped plastic body bag along with the identification tag of the patient, which is also marked as COVID-19 positive, before being transported from the isolation room or intensive care to avoid any leakage. Then the exterior of the body bag, that is the leak-proof zipped plastic body bag, should be decontaminated with 1% sodium hypochlorite solution, and then it should be either handed over to the relative or taken to the mortuary as soon as possible. All the used and soiled linen should be handled with standard precaution and disposed of in a biohazard bag. All the used equipment should be autoclaved or decontaminated with the disinfectant solution in accordance with the established infection prevention and control practice. All the medical waste must be handled and disposed of in accordance with the biomedical waste management rules, and health staff who handle the body should remove the personal protective equipment and then perform the hand hygiene. And in the end, counseling of the family member, if needed, could be done and sentiments should be respected. So coming to the environmental cleaning. Environmental cleaning in this case means all the surfaces that was earlier in contact with the patient. That is the floor, bed, railing, side table, IV stand, etc. it should be wired with 1% sodium hypochlorite solution, then give at least the contact time of 30 minutes, and then it should be followed by air drying. Handling of dead body in the mortuary. Mortuary staff handling the COVID dead body should observe the standard precautions. Dead bodies should be stored in cold chamber maintained at approximately 4 degrees Celsius. All the environmental surfaces, instrument and transport trolleys should be properly disinfected with 1% sodium hypochlorite solution. After removing the body, the chamber door, handle and floor should be cleaned with sodium hypochlorite 1% solution, and mortuary must be kept clean. Now, embalming. First thing we should know that we should generally avoid the embalming, but if there is some unavoidable circumstances, then it should be done with minimal invasive technique. Now, autopsy should also be avoided, but if there is some circumstances, it should be performed, but with the following the standard precaution, that is the hand hygiene and personal protective equipment. The team should be well trained in infection prevention and control practices. The number of forensic expert and support staff in the autopsy room should be limited. The team should use the full complement of personal protective equipment, and negative pressure to be maintained in mortuary. Round-end scissors should be used. PM40 or any other heavy-duty blade with blunted point to be used to reduce the prick injury. For the forensic expert, only one body cavity at the time should be dissected. An unfixed organ must be held firm on the table and sliced with a sponge. Care should be taken to protect the hand. An oscillator saw with suction extraction of the bone aerosol into a removable chamber should be used for sawing the skull, and otherwise a hand saw with chainmail gloves may be used. Needles should not be reseated after the fluid sampling, and needle and all the syringes should be placed in sharp bucket after the use. Reduce the aerosol generation during an autopsy using an appropriate technique, especially while handling the lung tissue. After the procedure, the body should be disinfected with 1% sodium hypochlorite and then placed in a body bag, and again the exterior should be decontaminated with 1% sodium hypochlorite solution. The body thereafter can be handed over to the relative, and autopsy table should be disinfected as per the standard protocol. Now, transportation. The body that secured in a body bag, exterior of which is decontaminated with 1% sodium hypochlorite solution. Now it will pose no additional risk to the staff that transport the dead, transporting the dead body. The staff handling the body may follow the standard precaution, and vehicle after the transfer of body to the cremation or for the burial will be decontaminated with 1% sodium hypochlorite solution. Now, at the cremation or at the burial ground, the cremation burial ground staff should be sensitized that COVID-19 now will pose no additional risk factor to get infected to others. The staff will practice the standard precaution of hand hygiene and use of mask and gloves. Viewing of the dead body by unzipping the face end of the body bag by the staff using the standard precaution may be allowed for the relative to see the body for one last time. Religious rituals such as reading from religious script, sprinkling holy water, and other last rite that does not require the touching of the body can be allowed, but bathing, kissing, hugging, etc. of the dead body should not be allowed. Large gathering at the crematorium or the burial ground should be avoided as a social distancing measure, as it is possible that close family contact may be symptomatic and or shedding the virus at that time. Electric or gas crematorium eliminate the chance of infection. The funeral and the burial staff and family members should perform the hand hygiene after the cremation or burial. As already told, cremation is recommended either by the electric or gas crematorium, and burial depending upon the religious sentiment. Burial should be done in thick airtight coffin placed at a depth of at least 4 to 6 feet below the ground. An area above and adjacent to the grave should be cemented and should also be marked immediately as an additional precautionary measures. The ash does not pose any risk and can be collected to perform the last rite. So I have collected my data from the following references, and anyone interested can go through these links for further study. And then my sincere thanks to all the contributors. Thank you.
Vineet, for your very lucid presentation. Now, like to invite Kanam to say a few words as we are coming to the end of the training day.
Thank you, Arisha. And with this, we come to the end of this training program. And before we start posters, I want to thank our DGME sir, who initiated this training program. And I think this training program will be helpful to all of us, not only for the management of children with COVID, but in management of children in general also. And I thank Dr. Shaili Avasthi ma'am, who is the main person for the academic
7 days
planning
10 days
and for the all coordination she is doing. And I thank all the speakers. So they are excellent job, and they are taking back-to-back lecture for last 2.5 months for this training program. And I thank Dr. Suyog, Mr. Neeraj, and the whole Mamta team who is working hard for this training program. They are sending emails, thousands of emails, and the link for the participant for last 2.5 months. So I thank them. And in the last, thank to all the participants for your active participation. So before we start posters, Mr. Neeraj will brief you about the posters. So all the best and thanks to all.
Thank you, ma'am. This is basically a sample of message what you have received on your WhatsApp regarding the 3-day links of day 2, 3, and 4. With that, you also have a post-test link at the bottom of the message. If you have already clicked on this link, I request you to please close that particular tab of your browser, as you have to click on this link when this link is activated. And if you have an issue, you have to just message on the number on WhatsApp from which you have received this message. I'm also showing you how it looks on your WhatsApp. You can see this message. It shows like 3 consecutive links, and you have to click on this read more. And you can see the posters link at the last. If it's not coming on the blue color, you have to save the number from which you have you are receiving this links. And if you are having any issue, please message on the number from which you have receiving these messages regarding the trainings. So I'm activating the link. Please click on that link after it's get activated. The link is activated. Dr. Deepika, I have just activated the link. I request you to click on it now. Thank you all. Priyanka, please close the meeting.